تمام، ممتاز. الكل أكد إن الحمد لله الصوت تمام، فهنبدأ محاضرتنا. دي المحاضرة الأولى في الكورس. بعد كده إن شاء الله الدكاترة هتبتدي تتعمق أكتر في تفاصيل الهايبركالسيميا والهايبو، ويتكلموا على الأوستيوبروزيس والريسك فاكتورز. النهاردة إحنا في محاضرتنا لمدة ساعة هنتكلم فقط عن مقدمة عن الأوستيوبروزيس، مقدمة بسيطة لأنها هتبقى التمهيد اللي هنكمل فيه باقي محاضرتنا، وهو الريهابيليتيشن اوف اوستيوبروزيس. ايه بالظبط البرنامج اللي بيتعمل من وجهة نظر الريهابيليتيشن بوينت اوف فيو للكيسز دي. بعد كده في باقي المحاضرات ان شاء الله هيتكلموا اكتر عن الباثولوجي والفسيولوجي فور ذا بروسيس بشكل كامل، وباقي كمان الاضطرابات. اول حاجة هنتكلم فيها what is the definition of osteoporosis. ايه هي الاوستيوبروزيس؟ زي ما احنا شايفين في الصورة كده، الفرق ما بين النورمال tissue bone and osteoporotic tissue bone. Osteoporosis is defined as low bone mineral density نتيجة لحصل alteration أو تغيير in bone microstructure. ده بيعرض العيان إن هو بيكون عرضة جدا fragility fractures، خاصة كمان لما بتكون low impact. ويمكن لما هنتكلم مع بعض ما بيبقاش فيه symptoms واضحة للأوستيوبروزيس. يمكن أول حاجة بتبقى وجه إنذار للعيان إن هو يبتدي يروح يعمل extra investigations ويشوف هو osteoporotic patients ولا لأ، لما يحصل له fragile fracture بسبب حاجة low impact أو normal daily activity عادي جدا يسبب له هو fracture، فيبتدي هنا يبقى ده جرس إنذار إن فعلا في osteoporosis موجود، ويمكن كان بقاله سنين والعيان مش حاسس بيه. Those osteoporotic fractures lead to significant decrease in quality of life، زي ما هنتكلم مع بعض بالتفصيل إزاي. وطبعا بيؤدي increasing morbidity خاصة in older age، وأكيد بيؤدي للدisability. وإن الأبحاث وجدت إن over 50% of postmenopausal women أكيد بشكل أو بآخر في وقت من عمرهم كان عندهم على الأقل مرة واحدة osteoporotic related fracture. So let's say إن osteoporosis is a metallic bone disease usually occurring with increasing age that mainly affect postmenopausal women and older people. وده ما يمنعش إن أوقات بيكون بنلاقي حالات الأوستيوبروزيس في العمر الصغير، ولكن مش بيبقى كتير قوي. معظم الحالات بتبقى الأولدر بيبول، خاصة السيدات في سن البوست مينوبوزال age. Fracture resulting from osteoporosis become increasingly common in women after age 55 years. ده الجولدن ايج للاوستيوبروزيس فراكشرز بالنسبة للسيدات، بينما بالنسبة للميلز هو سن 65 سنة. وزي ما قلنا إن دايما البون associated morbidities بتكون بتسبب low quality of life, increasing healthcare costs and increasing mortality. Wounds that commonly break include vertebrae in the spine, forearm, wrist and hip. من أكتر الأماكن دايما اللي بنشوفها في حالات كبار السن، وبيكون هو ده البوابة الأولى لكثير من الكوموربيديتيز بعد كده بالذات في السيدات، هو الفراكشر هيب. وانس إن حصل فراكشر هيب وما كانش فيه ريهابيليتيشن جيدة بعدها، وما كانش فيه عناية جيدة بالمريضة، بيبتدي إن ده بيبقى البداية لكثير من الكوموربيديتيز بعد كده. زي ما قلنا عادة البروكن بونز occur there are typically no symptoms until الفراكشر بيحصل. Bones may weaken to such a degree، ممكن يوصل الباثولوجي في البونز لدرجة إن مجرد minor stress أو بشكل تلقائي يحصل الكسر. بعد ما بيحصل الكسر بيكون في هيلينج، عادة بعد الهيلينج بيكون في chronic pain and decreasing في ال ability to carry out normal activities. ومن هنا بيجي دور ال rehabilitation program اللي بيتعمل، اللي بيكون فيه مسؤول بشكل أساسي طبعا الفيزيوثيرابيست، إن هو إزاي يحد أو يقلل من الكرونيك بين، ويبتدي يزود بالتدريج مدى الاعتماد على الذات في النورمال اكتيفيتيز اليومية. Osteoporosis has no symptoms زي ما قلنا and the person usually doesn't know that they have osteoporosis until a bone is broken. ودي بنلاقيها كتير جدا في العيادات، بنشوفها إن المريضة أو المريض، طبعا صيغة السيدات أكتر لأن هي most common في السيدات أكتر بسبب هرمونال امبالانس أو فترة البوست مونوبوزال بيريود. الفترة دي بتبقى related جدا بالأوستيوبروزس. السيدة بتتفاجئ إن هي عندها هشاشة في العظام، وقاعدة سنين، بقالها سنين بتتطور معاها وبتزيد طبعا. علشان كده بيبقى الكشف الدوري أو المستمر أو تجهيز الفترة دي من أهم الأشياء اللي ممكن حد يعملها في حياته يعني. فلما بيحصل الفراكشر في situation عادي جدا، في حاجة related بالنورمال activity، الشخص الهيلثي ما يحصلوش فيها فراكشر، بيبتدي هنا ناخد بالنا إن ده fragility fracture. ممكن تعمل تحاليل أو تعمل دكسة وتتأكد فعلا من وجود الأوستيوبروزس. واتفقنا إن ال most common areas for الفراجيليتي fractures عادة بتكون في الvertebral column، ودي بنشوفها كتير جدا، وفي الرب وفي الهب والريست. يمكن أكتر حد بنشوف الكلام ده فيه هو الvertebral column and hip. From examples of situation where people wouldn't normally break a bone، زي مثلا إن هي مجرد إن هي شالت حاجة بسيطة جدا من الأرض، مثلا رفعت الحقيبة بتاعتها، أو إن هي حصل بندنج فجأة، أو just coughing. يعني بعض الكيسز اللي بتبقى الحالة سيفير جدا ومش واخدة بالها بقالها فترة، just لو جالها دور coughing جامد وحصل كحة قوية جدا وبدأت إن هي تتهز بعنف، يحصل مثلا fracture hip. طيب what are the risk factors؟ إيه هي risk factors for osteoporosis؟ The risk of having osteoporosis includes age and sex. طبعا قلنا إن الفيميلز معرضين أكتر لحدوث الأوستيوبروزيس وتطورها عبر الوقت. الريسك فاكتورز مقسومة جزئين أو ليها two types. في non modifiable، حاجات غير قابلة للتعديل مش هنقدر نعدلها وهنتكلم عنها دلوقتي، وفي حاجات قابلة للتعديل. الغير قابلة للتعديل زي الage. Some medication may be necessary to treat a different condition زي السكس زي ما قلنا، وهنتكلم في بقية الفاكتورز مع بعض. وفي حاجات قابلة جدا للتعديل، إن بمجرد تعديل اللايف ستايل أو عادات معينة المريض أو المريضة بيعملها بتقلل جدا من سرعة تدهور الحالة. طيب خلينا نتكلم الأول على non modifiable risk factors. أول حاجة وأهمهم طبعا ال advanced age in both men and women. ويمكن كمان زي ما قلنا إن being female ده بيبقى عرضة أكتر لحدوث الأوستيوبروزس نتيجة للأستروجين deficiency following المونيبوز، أو سيدات كتير بتخضع ل surgical removal of the ovaries which is correlated very rapidly with reduction in bone mineral density. لو كانت السيدة دي مش مؤهلة ومش مجهزة بالعوامل اللي هنتكلم فيها، زي مثلا النيوتريشن بلان، زي الريهابيليتيشن بلان المخصوصة ليها، لو الحاجات دي كلها مش موجودة بتكون هي عرضة أكتر لوجود الأوستيوبوروزس. الأبحاث مش مبينة قوي هل مثلا كمان لو عرضة الميلز للموضوع ده بسبب مثلا التستوستيرون ليفل لو حصل فيه ديكريز نتيجة لمرض ما، هل ده بيأثر بصورة مباشرة ولا لأ؟ الليتريتشر مركز أكتر أو في علاقة وثيقة أكتر ما بين الاستروجين deficiency in females وما بين وجود الأوستيوبروزس. يبقى إذا من العوامل النون موديفايبل، أول حاجة اتكلمنا عنها قلنا الادفانسد ايج في الاتنين على حد سواء المين اند الومن. لو دخلنا فاكتور تاني وهو الجندر، فالبينج فيميل ده عرضة أكتر نتيجة للإستروجين ديفيشنسي اللي كده كده بيحصل في وقت المينوبوز، بيزيد عليه كمان لو السيدة دي تعرضت لسبب ما لسيرجيكال ريموفال للأوفرز، فبالتالي ده بيحصل reduction in bone mineral density، وبالتالي بتكون عرضة أكتر وأسرع لوجود الأوستيوبروزس. طيب إيه تاني العوامل اللي هي risk factors and non-modified زي الإسينيتي؟ معظم الأبحاث اللي اطلعت عليها كان بيتكلموا إن في أعراق معينة عرضة لنشوء الأوستيوبروزيس أسرع وأكتر من باقي الأعراق الأخرى، زي مثلا اليوروبيان أند إيشن عرضة أكتر لوجود الأوستيوبروزيس. العامل اللي بعد كده وهو الفاميلي هيستوري. الفاميلي هيستوري للفراكشرز بصورة عامة أو الأوستيوبروزيس بيزود احتمالية وجود إن الشخص اللي حامل الجينات، ويمكن تقريبا حوالي 30 جين بيبقوا related بنشوء الأوستيوبروزيس أو صحة العظام بصورة كاملة. What about the modified risk factors؟ إيه هي الموديفايد اللي related بحاجة نقدر نعملها بالبرنامج اللي بيتحط للمريض أو للمريضة بحيث إن هو يأخر تدهور الحالة أو يمنع وجود recurrent fragile fractures؟ أول حاجة vitamin D deficiency. Low circulating vitamin D is common among the old people worldwide. بصورة عامة دي مشكلة كل البلاد تقريبا بتعاني منها. Mild vitamin D insufficiency is associated with increased parathyroid hormone. أكيد الباراثايرويد هرمون بيزود جدا البون ريسوربشن، زي ما هنشرح دلوقتي ايه هي عملية البون ريسوربشن وبتحصل ازاي. من أهم العوامل اللي بتؤدي للعملية دي إن يحصل تفتت للعظام أو فقدانها، إن يكون في increasing للباراثايرويد هرمون بصورة غير مألوفة أو غير طبيعية، وده نتيجة لل insufficiency in vitamin D. رقم 2 من العوامل اللي هي قابلة للتعديل بس من أهم الريسك فاكتورز وهو التوباكو سموكينج. السموكينج بصورة عامة ليه أضرار كتير، من أهمها إن هو inhibit the activity of osteoblasts، وهنتكلم دلوقتي عن دور الأوستيوبلاستس لما نيجي للجزء بتاع البون ريموديلينج. العامل رقم 3 المال نيوتريشن، ويمكن في محاضرة في الدورة دي بتتكلم عن النيوتريشن بصورة مفصلة أكتر للحالات دي وإيه اللي مطلوب ليهم أكتر. malnutrition as risk factor في غاية الأهمية and play very complex role in maintenance of good bone. من أهم الريسك فاكتورز اللو dietary كالسيوم، الفوسفورس، المغنيسيوم، زنك، البورون، الايرن، الفلورايد، الكبر، فيتامينز زي فيتامين A، فيتامين K، فيتامين E، فيتامين C، وطبعا أهمهم بالنسبة للي بنتكلم فيه فيتامين D. فالنيوتريشن بتلعب دور حقيقي مهم جدا في البون هيلث. من العوامل كمان القابلة للتعديل being underweight، وهنتكلم ونشرح بالتفصيل ازاي الويت بيرنج مهم جدا في عملية البون ريموديلينج. كل ما بيحصل physical stress على البون نتيجة للفيزيكال اكتيفيتي ده بيؤدي ان يحصل البون ريموديلينج بصورة صحيحة. لذلك physical inactivity can lead to significant bone loss، وده اللي بيخلي إن في قابلية للتعديل. لما ما يبقى في inactivity يحصل bone loss، يبقى إذن لو حصل physical activity بالصورة المطلوبة باللود اللي احنا محتاجينه، يحصل عكس العملية، يحصل الريفيرس، يبتدي يبقى فيه بناء جديد. وده اللي بنعتمد عليه بصورة أساسية في برنامج التأهيل زي ما هنشرح مع بعض. So let's say إن ال weight bearing exercises can increase peak bone mass and there is highly significant correlation between bone strength and muscle strength. Let's say also the incidence of osteoporosis is lower in overweight people نتيجة للأوفر ويت بيرنج اللي بيتعمل بمجرد الووكينج، جاست ووكينج، بيحط ستريس على البون أكتر من الشخص اللي هو أندر ويت، فبالتالي بيكون ده عرضة أكتر لوجود الأوستيوبروزيس. الفاكتور اللي بعد كده وهو الهيفي ميتالز. Strong association between some heavy metals like cadmium and lead with bone disease. في كثير من الدراسات بحثت هل في علاقة ما بين وجود الكادميوم والليد في الانفايرومنت بشكل عام وما بين وجود بعض البون ديزيز ولا لا. وجدوا ان في علاقة وثيقة ما بينهم، ان اللو ليفل exposure to cadmium is associated with increased loss of bone mineral density. وده كان على in both genders على حد سواء يعني. وجدوا كمان إن في علاقة ما بين وجود البين و increasing fractures خاصة في السيدات الكبار في السن. طيب العامل اللي بعد كده and can be modified هو السوفت درينكس، خاصة السوفت درينكس which contain phosphoric acid بيتزود جدا الريسك of osteoporosis. طيب ايه كمان من العوامل اللي هي قابلة للتعديل؟ بروتون بامب inhibitors. الناس اللي بتمشي على البروتون بامب انهبيتورز لسنتين فيما هو فوق بيكون عرضة أكتر لحدوث الأوستيوبروزيس، وده طبعا نتيجة ل decreasing in the production of stomach acid which is risk factor for bone fracture لأنه بيقلل absorption of calcium in the stomach. So let's say إن في risk factors قابلة للتعديل زي اللي شرحناهم وغير قابلين للتعديل. وطبعا في كثير many diseases and disorders associated with osteoporosis هتتشرح إن شاء الله بالتفصيل أكتر في المحاضرات القادمة. إيه هي الديزيزز والعوامل الريسك فاكتورز اللي ليها علاقة بوجود الأوستيوبروزيس؟ هل هي علاقة straight forward ولا just unknown reason أو multiple causes مثلا بتؤدي لوجود الأوستيوبروزيس؟ What are the biological causes of osteoporosis؟ إيه هي العملية بالظبط بتحصل إزاي؟ In adults, there is daily removal of small amounts of bone mineral. يوميا إحنا بنتعرض لعملية اسمها bone resorption، وده من رحمة ربنا إن هي بتكون balanced by equal deposition of new mineral in order to maintain bone strength. دايما إحنا خاضعين لعمليتين عكس بعض، bone resorption and bone deposition. When this balance، لما البالانس ده يميل أكتر أو shifted أكتر ناحية البون resorption، هنا بيحصل bone weaken and over time become more brittle، أكثر هشاشة and more prone to fracture، وينشأ حدوث الأوستيوبروزيس. So the balance between bone resorption and bone deposition is determined by activities of two principal cell type. عندنا نوعين من الخلايا بالأساس هم المسؤولين على عملية resorption and deposition. الأوستيوكلاستس and osteoblasts. لازم طول الوقت يبقى فيه balance between the two activities to maintain healthy good state. However, skeleton is alive and must be able to grow, heal and respond to its environment. وده أمر طبيعي جدا. So let's say إن bone remodeling plays an important role. However, as we age مع تقدم السن, daily remodeling leads to gradual resorption of minerals inside the cortical layer, and in bone cavity itself leads to high loss of trabecular bone and widening in the bone cavity. وده لحد ما compensated by gradual addition of extra layers of mineral to the outside cortical layer. بس الcompensation ده لو حصل فيه خلل ما لأي سبب من اللي قلناه فوق، وجود الريسك فاكتورز دي كلها كانت موجودة سواء بنسبة كلها أو حد منها، بيعيق البالانس في العملية، في عملية البالانس ما بين remodeling of the bone to maintain healthy structure. Because the bone formation phase typically takes much longer than the resorption phase، ودي طبعا يعني من رحمة ربنا، any increase in remodeling activity tend to result in a net loss of bone. كان الصورة موضحة جدا الفرق ما بين المايكروستراكشر في النورمال بون ماتريكس and what is the difference in osteoporosis. At various stages throughout this process, osteoclasts and osteoblasts communicate with each other through releasing virus signaling molecules. However, molecules دي and other endogenous factors like مثلا hormones أو external factors like diet and exercise influence the cell involved in bone physiology. وده موضوع كبير، بحث كبير جدا لدراسة كل العوامل، سواء العوامل الخارجية أو العوامل الداخلية زي مثلا الهرمونز، أو الخارجية زي كل الريسك فاكتورز القابلة للتعديل اللي اتكلمنا عنها، من أهمها طبعا الدايت والفيزيكال اكتيفيتي والاكسرسايز، أو أي لود بيتحط بشكل عام على العظم. كل الفاكتورز دي هي مجال كبير جدا للدراسة وللبحث، وإن إزاي نوجد العلاقة ما بين الاكسترنال والانترنال، وهل في فاكتورز اكسترنال قابلة للتعديل بحيث إن هي تمنع تدهور الحالة وتحاول تعيد أو ريجين البالانس between the two process، بحيث إن احنا نأخر تدهور الحالة بشكل مطلوب. So let's revise. خلينا نذكر كمان عشان هنحتاج ده what is the modifiable risk factors اتكلمنا عليها. اتكلمنا عن الفيتامين دي deficiency والمالنيوتريشن، وقلنا إن شاء الله في محاضرة بالتفصيل عن الجزء ده تحديدا هتاخدوها. اتكلمنا عن السموكينج، إن هو بيعمل inhibition to the activity of osteoblasts، وده بيعيق أو بيأخر remodeling process of the bone. اتكلمنا عن الاندر ويت، ان الاكسسيف اندر ويت ده بيقلل الستريس اون بون، وبالتالي بيزود البون لوس، وان كل ما كان في ستريس او في فيزيكال ستريس مينلي، في وزن زياده على البون او في فيزيكال اكتيفيتي زي ما هنشرح ازاي بيتعمل، ده بيزود increase البون ريموديلنج بصوره صحيحه. اتكلمنا عن الهيفي ميتالز والسوفت درينكس والبروتون بامب انهبيتورز، ان كل دي عوامل قابلة للموديفيكيشن خارجية، ولكن بتأثر في البالانس اوف بون ريموديلنج. طيب خلينا بقى هنتكلم دلوقتي عن الاوستيوبوروزس ريهابيليتيشن. ايه بالظبط اللي بيتعمل، ايه البرنامج المطلوب، وايه الافكت فور osteoporosis. The goals of rehabilitation change depending on the stage of disease. أمر طبيعي. According to each patient, individually according to its stage of disease، بنبتدي إن احنا نحط ال goals of rehabilitation، وبالتالي بيبقى ليه specific program. في ناس بتكون الجول just prevention لو كانت الحالة لسه لم تتدهور بصورة كبيرة أو كانت لسه في الأول. في cases تانية بيكون لأ، خلاص وقت البريفنشن عدى، بنبدأ إن احنا نحاول نعمل reverse action للعملية. وهنتكلم برضو من أهم العوامل اللي بناخد بالنا منها جدا في التقويم، إن احنا بنحط برنامج to prevent falls. سقوط كبار السن من أكتر المشاكل اللي بتواجههم، وبيبقى ليها برنامج خاص، وبيبقى مالتي فاكتوريال بروجرام زي ما هنتكلم فيه مع بعض. إن من أهم الحاجات اللي بتتقيم هل الشخص أو المريض اللي جاي في السن ده ومعاه أوستيوبوروزس هل هو عرضة بنسبة قد إيه for frequent falls، وإيه العوامل اللي أدت لكده. لذلك المودرن rehabilitation shouldn't only focus on bone strength. احنا مش بنعمل برنامج خاص فقط for bone strength، بينما هو بيبقى ترايات كده، مثلث. بنركز طبعا على البون strength لأن هو ده هدفنا in this patient، بس مهم جدا إن احنا كمان بندي اعتبار وأهمية for muscle strength and balance. يعني to gain muscle strength هيأثر بصورة كبيرة جدا على البون strength، وبالتالي لو ظبطنا البون strength والmuscular strength وبدأنا نعمل تدريبات مثلا وليكن like balance exercises، فالترايات ده بيحافظ على الفيزيكال activity level إن هو يبقى optimum for the older people. خلينا كمان نقول إن pharmacological treatment increase bone strength، ولكن ملوش تأثير مباشر على المسل سترينسنج أو على البالانس. يعني ممكن العيان ياخد فيتامين دي، أوكي، هيحصل improvement، ممكن نظبط النيوتريشن، but still الفيزيكال activity دورها مهم جدا وليها دور مباشر في تحسين الحالات. according to الكيس، according to الاسسمنت اللي حصل، في حالات بتبقى محتاجة طبعا تعديل في النيوتريشن بلان، محتاجة supplements زي الكالسيوم أو فيتامين دي، محتاجة exercise program بسيكونس معين. في بيبقوا محتاجين أورثوزس، تدخل حد عشان يعمل أورثوزس مناسبة ليهم. في بيبقوا محتاجين كمان psychological support، لأن تكرار حالات الفولينج زي ما هنشرح بيكون في عامل مهم جدا، عامل النفسي اللي هو الخوف من الوقوع المتكرر، ده بيخليه يقع أكتر. وهنشرح دلوقتي الريسك فاكتورز فور فولينج بالتفصيل. طيب خلينا، يمكن حد بيسأل دلوقتي ايه العلاقة ما بين الفيزيكال اكتيفيتي وما بين ان انا اعمل لود اند ستريس اوفر بون، وما بين ان انا كده بحفز عملية الريموديلينج اكتر. خلينا نشرح النظرية دي بمنتهى البساطة، هتفهمكم اكتر المعنى. ميكانوستات theory which is related for the targeted exercise for bone loss prevention. How exercise prevent loss of bone. Mechanical stimulation generated by exercising. وجود الميكانيكال ستيموليشن والويت اللي بيحصل او الستريس اون ذا بون نتيجه للبادي، الويت بيرنج او عامل الجرافيتي او كل الحاجات دي. هنا بيحصل ايه بقى؟ ده اللي هنشرحه مع بعض. The bone as material is weakened by repeated strain. امر طبيعي جدا، اي material by repeated strain هيحصل لها weakening and causing minor damage to bone structure. ولكن وده من رحمة ربنا إن في عملية عكسية في نفس الوقت بتحصل. On the other hand, stress strain that exceed certain threshold leads to generation and adjustment of the strength of bone load. So this السايكل دي ما بين وجود الريبيتد سترين والماينور دامج اللي بتحصل، والعكس العملية ان لما بيحصل ستريس وبيحصل لودنج ده بيحفز اكتر عملية البناء والريموديلنج. البالانس ده والسايكل فيدباك دي هي ده المعروف بيه الميكانوستات ثيوري. Physical activity targeting muscles is the cornerstone of each rehabilitation program for prevention of bone loss. زي ما اتفقنا مع بعض احنا مش بنركز بس على البون سترينث ونتغافل الماسل سترينث، لا، ده الفيزيكال اكتيفيتي بروجرام المظبوط او الريهابيليتيشن المظبوط بيكون mainly التارجت لينا هو الماسل سترينث. which results of physical activity studies on the positive association of physical activity with bone status, and also there is positive association ما بين البون status and the muscle strength. So it is clear that the physical activity is vital in adults، خاصة في السيدات، لأن كل ما بيحصل الويت بيرنج exercises أو الويت بيرنج activities كل ما بنزود عملية الريموديلنج أو البالانس فيها بصورة أفضل وبصورة أصح، وده بيقلل من تدهور الحالة because it reduces the rate of bone loss during البريمenopausal زي ما شرحنا نتيجة decrease in estrogen and decelerate bone loss associated with aging. The osteogenic effects of exercise should be specific to anatomical sites where mechanical strain occur. ويمكن ده مبدأ في غاية الأهمية إن الاستوجينيك effect للإكسرسايز الإفكت اللي احنا شرحناه ده وهو البالانس ما بين الماينر دامج اللي بيحصل وما بين الريبيلدينج بنسميه الاستوجينيك effect، بيكون سبيسيفيك على الاريا اللي حصل فيها الميكانيكال سترين او الميكانيكال ستريس، مش بصورة عامة بيبتدي يحصل توزيع كامل في باقي العظام في الجسم، لا. وليكن مثلا لو في بيشنت بيبتدي ان هو يعمل resistance exercise او weight bearing exercise على الفور ارم مثلا فور ليفت هاند، هنتوقع ان الطبيعي ان الاستروجينيك افكت ده أو التأثير الإيجابي أو الميكانيكال لود اللي شرحناه هيفضل موجود في الإيد اللي اشتغل بيها، بينما الإيد التانية مش هيحصل فيها أي حاجة. لذلك الميكانيكال سترين بيحصل أو الفايدة بتحصل قصرا أو سبيسيفيك على الاناتوميكال سايز اللي حصل عليه الميكانيكال سترين. The most common types of physical activities مثلا وليكن السويمنج. السويمنج ملهاش علاقة خالص باللي احنا بنتكلم فيه، ليه؟ لأن مفيش فيها ويت بيرنج، ده فيه العكس، المية بتخفف من الويت of the body، فهنا many muscles هتبقى involved طبعا but no target for loading، مفيش loading هنا. Therefore don't produce loads heavy enough to exceed the load threshold on bone achieved by usual daily activities. يبقى إذن مثلا لو في الريهابيليتيشن بروجرام لحالة اوستيوبروزس أكيد مش هنختار السويمنج، مش هيكون هو ليه الأولوية كفيزيكال اكتيفيتي لأن التارجت بتاعه مش موجود. there is no targeted bone loading، ده حصل العكس، حصل فيه bone unloading بسبب المية. فدي نقطة تانية برضو مهمة إن according to the degree of الويت bearing، وطبعا ده بيختلف من اكسرسايز للتاني، يعني الووكينج ده الويت بيرنج غير الرننج غير الجوجينج غير الريزيستنس اكسرسايزز، كل اكسرسايز من دول بيكون ليه ليفل مختلف عن التاني related بالويت بيرنج، فبالتالي بيكون ليه degree مختلفة from the wound loading. وطبعا أول ما بنبتدي برنامج rehabilitation بيكون فيه تدرج، ما أقدرش فجأة حالة العيان لا تسمح وهو دلوقتي في حالة متدهورة أو معرض للفراجايل فراكشرز بصورة كبيرة أبتدي عليه بهاي لود اكسرسايز، أنا كده بعرضه أكتر للمشكلة. ولكن مهم قوي إن بيبقى فيه تدريج للبروجرام of the rehabilitation according to the degree of weight bearing اللي العيان يقدر يستحمله دلوقتي. The duration of physical activity is also important، مهمة جدا. معظم التوصيات in the recent literature إن محتاجين على الأقل ساعتين في الأسبوع. طبعا الرقم بيتغير من مرجع للتاني أو من جايد لاين للتاني، بس المتوسط بيبقى تقريبا ساعتين في الأسبوع باستخدام الويت بيرنج تكنيك الصحيح اللي هو related للحالة والديجري بتاعتها. ده بيكون ليه بوزيتيف افكت على البون ماس مينتيننس. زي ما قلنا we have different exercise techniques that affect the mechanical properties of bone. عندنا مثلا resistive exercises اللي هي anaerobic exercises in form of strength training program، بنستخدمها mainly for increasing muscle strength, enhancement of bone mass, improving balance and improving الموبيليتي. وبالتالي لما بيحصل ان احنا عملنا strengthening for the muscle، عملنا enhancement for the bone mass، عملنا improving للبالانس، زودنا الموبيليتي، كل ده بينعكس ان احنا بنعمل improvement for quality of life. There is also another type of exercise which called weight bearing، وده منتشر أكتر بكتير لأنه معظمه مش محتاج أدوات أو محتاج مثلا جيم أو حاجة. It's most popular ما بين كل الفئات العمرية تقريبا. التايب ده جميل قوي لأن هو بيعمل generating ل high mechanical load of bones. يعني مش just إن أنا بعتمد بس على الويت بيرنج بستخدم وزن الجسم، أنا كده مش بحقق highest mechanical load، إنما بالعكس زي ما اتفقنا مثلا إن الرانينج الجوجينج أنا بضاعف الويت بيرنج، بضاعفه أكتر مثلا من just walking. فالتدريج ده ما بين الووكينج والرانينج والجامبينج، وإن أنا أمشي بالتدريج لأن في كل مرحلة بزود الويت بيرنج لأن رد فعل الجاذبية بتاعة الأرض بتكون أكبر على الجسم، بيكون مهم جدا ومطلوب للحالات دي تحديدا. Weight bearing or loading adds stress to the bones that stimulate bone building زي ما اتفقنا. The load slightly compress the bone matrix and trigger the cells to take in more calcium and more mineral. So this increase the bone density. كل ما بيحصل ستريس ميكانيكال ستريس اكتر نتيجة للويت بيرنج، نتيجة لللودنج، نتيجة للاكسرسايز المناسب للحالة، كل ما بيزود اللود اللي بيعمل كومبريشن على البون ماتريكس بيحصل تريجرنج للسيلز تو تيك مور كالسيوم، يزود عملية البناء عشان تعمل تعادل أو تلاحق على عملية الريزوربشن اللي بتحصل، وبالتالي بيزود البون density. The amount of weight that cause this response، والجملة دي في غاية الأهمية، المصطلح ده مهم قوي. إيه هو يا ترى الويت المناسب اللي لما أحطه على البون يبتدي يعمل لي العملية اللي احنا قلنا عليها، يبتدي إن هو يزود البالانس في الريموديلنج، يبتدي إن هو يعمل كومبريشن على البون بصورة صحيحة، ويزود التيك فور كالسيوم أند أذر مينرالز. يا ترى الويت ده قد إيه؟ الويت ده احنا بنسميه اسم هو الاستيوجينيك لودنج because it takes a certain load to stimulate the bone. في certain load for each case for each patient عشان يحصل triggering to this process to stimulate the bone building cells. in contrast وفي العكس بيحصل عكس العملية زي ما اتفقنا، هو ال unloading، وده بيحصل نتيجة للبرولونجد بيد ريست. فاكرين لما قلت لكم إن الفراكشر هيب في السيدات البوست منبوذل بيكون هو بداية، ودي أنا شفتها في حالات كتير كتير، بيكون هو بداية كثير من الكوموربيديز لو ما تلحقش واتعمل ليه عناية جيدة، لأن البرولونجد بيد ريست بتعمل عكس العملية. احنا كده عاملين unloading to the bones، فبالتالي الريموديلنج بيتراجع، بناء العضلات العظام بيتراجع، بيقل جدا نتيجة للأنلودنج، خاصة لما بيطول شهور كبيرة أو ما بيحصلش أنلودنج بصورة سليمة. فده بيؤدي إن العيانة أو المريضة دي بتدخل في كثير من الكوموربيديز بعد كده، ومعظمها بيبقى صعب إن هو يتلحق يعني. طيب احنا اتكلمنا عن الانيروبيك اكسرسايز او الويت بيرنج او الريزيستنس اكسرسايز، كلها مسميات قريبة من بعض او التكنيك بتاعها قريب. طب ايه النوع التاني؟ هو الايروبيك اكسرسايز. الابحاث وجدت ان هو ملوش تأثير مباشر على النقطة اللي بنتكلم فيها تحديدا، ان الافكت of aerobic exercise on bone density has been studied by review papers that report decrease in bone loss as a spine and wrist but has no effect عند الهب. في دراسة بحثت عن تأثير الايروبيك اكسرسايز على البون دينستي، وجدوا ان في تعديل بسيط او في اختلاف بسيط مثلا في السباين او في الريست، بس ما كانش ليه تأثير مباشر على الهب. في نتيجة لميتا اناليسز وجدت ان كان ميتا اناليسز، وهو بتكون high in the evidence pyramid، بتكون عبارة عن تجميع كذا study، وبنشوف الحكم بتاعها بعد تحليل إحصائي بيتعمل. ده معنى كلمة ميتا أناليسيس. وجدوا إن effects of walking on bone density showed that walking has a small effect on bone density at the spine. هما كانوا هنا بيقيسوا هل الووكينج كنوع من أنواع الويت بيرنج اكسرسايز ليه علاقة بالبون دينستي في البوست منوبوزال وومن ولا لأ. نتيجة الدراسة ما وجدوش إن في تطور كبير بالنسبة للسباين، بس وجدوا إن في significant positive effect on the femoral neck، إن في positive effect معقول في الفيمورال neck للحالات اللي خدوها. These studies conclude that other types of exercises، الexercises اللي اتكلمنا عليها زي مثلا الويت بيرنج، الريزيستيف exercise، أفضل في الإفكت اللي هو related بالبون remodeling and وجود البالانس، أفضل بكتير من الأيروبيك exercise. The physical activity guidelines recommended 150 minute تقريبا من المودريت physical activity every week. الأقوال بتتراوح من 120 ل 150 minute في الأسبوع، بيكون كافي جدا for the physical activity for bone health maintaining bone health. وطبعا بيتم التركيز على muscle strength خاصة for all major muscles، لأن اتفقنا إن إحنا عندنا التيرويد مثلث لا يمكن الاستغناء عن أحد من أضلاعه أثناء الريهابيليتيشن بروجرام، وهو البون سترينث، الماسل سترينث and regaining البالانس، أو إزاي نقدر نعمل تدريب متماثل، إن إحنا لا نهمل أي عنصر من الثلاث عناصر لأنهم كلهم مرتبطين ببعض وكلهم بيأثروا في بعض. ملحوظة مهمة جدا: doing many repetition with light weights is not the way to go. وده related بتعريف الايروبيك اكسرسايز. مهما عمل repetition from light weight هو ما عملش لود. احنا اتفقنا ان في حاجة اسمها استروجينيك لود، في لود معين لازم اوصل له ده اللي بيعمل ستريس على البون، ده اللي بيؤدي ليه الفوائد اللي اتكلمنا عليها كلها. لذلك add sufficient load on bones مهم جدا. The muscle you are working should be fatigued. لازم العضلة يحصل لها fatigue، لازم يحصل لها على الأقل من 12 ل 15 repetition بين قوسين with the optimum load، باللود المناسب للعضلة عشان يحصل strength، وبالتالي يحصل loading على البون، وبالتالي يحصل initiation for the remodeling balance again. Let's talk about the whole body vibration. زي ما شايفين في الصورة كده، ده بيبقى شكل الجهاز. في طبعا أبحاث كتير قوي بتتكلم عن أهمية الهول بودي فايبريشن، بس احنا هنتكلم عن الجزء اللي يخصنا في المحاضرة، إن هو بيساعد جدا إن يحصل ميكانيكال لود على البون. The mechanical loading of bone can be done with application of non-physiological factors زي جهاز الهول بودي فايبريشن مثلا، إن هو بيعمل combination ما بين ال dynamic loads and the high intensity loading on the skeleton. اللود اللي بيتعمل في الجهاز وال strong vibration طبعا بيبقى ليه degrees according to the case، بيساعد جدا إن هو يعمل كل العملية اللي احنا شرحناها في الإكسرسايز العادي. The vibration is a mechanical stimulation of the whole body. The person is standing on the vibration platform, trying to keep his head and body straight and upright. بيحصل فيه محاولة إن الجسم يفضل، المريض اللي واقف بيحاول طبعا according to the intensity of the device إن هو يحافظ على الهيد والبودي straight and upright ويتمسك ويحاول إن هو بقدر الإمكان يحافظ على البالانس بتاعه. وجود اللود الميكانيكال ستيميوليشن ده بيساعد جدا في وجود الستريس المناسب على البون. Evidence from previous studies suggests that the more osteoporotic individuals may potentially increase bone mineral density values more from whole body vibration. We found also systematic review and meta-analysis found significant but small improvement. هو كان significant but مش improvement كبير in bone mineral density in most post-menopausal women and children اللي استخدموا معاهم الجهاز اللي هو الهول فايبريشن بودي. زي مثلا الصورة دي موضحة الهول فايبريشن في كذا بوزيشن. according to البوزيشن بيكون فيه هدف، بيكون ده الجول اوف rehabilitation. يعني مثلا الصورة الأولى just for balance and full prevention، بنبتدي إن هو العيان يحاول يجين البالانس أو وقت الفايبريشن فول ويت بيرنج، وبعد كده بيستخدم رجل ورجل. الصورة التانية مثلا ممكن نستخدمه في ال flexibility and range of motion increasing range of motion. الصورة التالتة knee rehabilitation، ممكن نبتدي إن احنا نخصصه أكتر في يكون موجه للني rehabilitation مثلا أو الأنكل rehabilitation خاصة بعد العمليات. just ممكن يستخدم for general health and wellness. ممكن كمان يكون بنستخدمه ليه استخدامات تانية النيورو ماسكولار ري education، ودي بنشوفها من أهم أجزاء الريهابيليتيشن هو النيورو ماسكولار ري education في حالات كتيرة جدا، خاصة بعد سيرجيكال بروسيجرز معينة بيكون وجود النيورو ماسكولار ري education في غاية الأهمية. ممكن الصورة اللي قبل الأخيرة just for bone and joint rehabilitation، وده اللي بنتكلم عليه إن الميكانيكال ستريس اللي بيتعمل ده بيساعد جدا في to regain the balance in the remodeling. ممكن كمان just يستخدم إن هو just low back pain، فليه استخدامات كتيرة جدا ال vibration on the body، وفي evidence كتير عن الموضوع ده بيرجح استخدامه with age بأي intensity بالظبط. من أهم الأجزاء اللي بنستخدمها في rehabilitation program for these cases، وهو جزء related بال frequent falling. The individual risk factors for fall in old people بتتلخص في حاجتين أساسيتين: intrinsic risk factors و extrinsic risk factors. From the intrinsic risk factors طبعا ال history of falling بيأثر جدا، ال age ليه عامل كبير، الجندر زي ما اتفقنا إن عادة الفيميل بتكون عرضة أكتر for risk of falling نتيجة لأنها عرضة أكتر للأوستيوبروزس. رقم 3 ال sedentary life نتيجة مفيش loading كافي، no physical activity بصورة كافية. الريس بعض الأعراق أو الإثنيتي زي ما قلنا، يمكن الأوروبيان أند إيشن مور أكتر عرضة إنهم يبقى عندهم risk for fallings. some drugs, some medical conditions, impaired mobility, impaired gait ليها علاقة طبعا أكيد بتأثر تأثير مباشر for increasing the risk for falls. psychological conditions، عشان كده زي ما قلت لكم في أول المحاضرة إن أوقات بيكون الريهابيليتيشن بروجرام ليه عدة جوانب، من أهمها التأهيل النفسي للمريض. مش لازم يكون في أخصائي نفسي مباشر، بينما الفريق الطبي نفسه يكون مراعي إن المريض ده محتاج psychological support، محتاج حد يتكلم معاه، محتاج حد يطمنه. إن أوقات كتير بيكون تكرار السقوط لكبار السن مجرد خوف نتيجة للهيستوري اوف فولز اللي عنده، حصل له إصابة بالغة، مجرد تكرار الخوف ده بيدخله في vicious circle إنه أكيد هيقع تاني كذا مرة، فبيخليه إن هو عنده تأهب للحركة، فبالتالي يخش في impaired mobility ويحصل unloading، ونخش في الفيشس سيركل دي لا تنتهي حتى يتم كسرها بوجود السايكولوجيكال سبورت. من أهم طبعا الانترنسيك ريسك فاكتورز زي ما قلنا النيوتريشن، خاصة لما بيكون الديفيشنسي كبير وبقاله فترة كبيرة من الزمن بيأثر تأثير مباشر طبعا. والكوجنيتيف ديس اوردرز أكيد ليها دور، وطبعا الفيجن مهم قوي. وكل الحاجات دي في منها طبعا قابل للتعديل وفي منها غير قابل للتعديل. وآخر واحدة هي الفود بروبلمز، إن لو في فود بروبلم أكيد بيكون في جيت impairment، بيكون في impaired mobility، وبالتالي بيكون في صعوبة في الحركة وبيزود الريسك for falling. طيب what about extrinsic risk factors زي poor lighting، slippery floors، uneven surfaces؟ كل دي حاجات بسيطة جدا وقابلة للتعديل. بنعرفها منين؟ بيكون في assessment tool خاصة for the risk factors for falling for older people، وده برانش مهم جدا في الريهابيليتيشن، لأن إن أنت تعمل prevention للمشكلة دي قبل حدوثها، خاصة للعيانين الأوستيوبروزس، ده بيوفر كثير من الكوموربيديتس، بيوفر كثير من التكلفة، بيوفر حاجات كتير قوي على المريض وعلى التكلفة الصحية العامة، إن ما يتعرضش خالص للمشكلة دي، لأن أوقات في فولينجز بتكون فعلا life threatening يعني. So let's say prevention of falls may be even more effective when taking into account of multiple risk factors. زي ما اتكلمنا إن أوقات كتير بيبقى just prevention ده مش بتحكم في risk factor واحد، أوقات على حسب الكيس بيكون البروجرام must be multifactorial وفي كذا فاكتور، إن إحنا إزاي نعمل prevention for the خاصة مع frequent fallings. طيب إحنا كده اتكلمنا على إيه من أول المحاضرة؟ مقدمة بسيطة جدا عن الأوستيوبروزيس، اتكلمنا عن تعريفها، وإن مين عرضة أكتر وليه السبب، واتكلمنا عن السيمتومز، قلنا مفيش سيمتومز ممكن تكون واضحة، وإنما لما بيحصل فراجايل فراكشر بيبتدي هنا ده علامة الخطر إن في مشكلة، ومن ثم تتوجه الحالة وتكتشف وجود الأوستيوبروزيس وبأي نسبة. اتكلمنا عن الريسك فاكتورز، إن في منها غير قابل للتعديل وفي منها قابل للتعديل. اتكلمنا عن البيولوجيكال كوزز فور osteoporosis وشرحنا مقدمة بسيطة عشان تدخلنا على معنى كلمة الميكانيكال لودنج اون بون، وازاي بنستخدم الكونسبت اوف ذا ثيوري اللي شرحناها في اللي هي الميكانوستات ثيوري، شرحناها بالتفصيل ازاي بنستخدم الكونسبت ده في الريهابيليتيشن بروجرام. اتكلمنا عن انواع الاكسرسايز، اتكلمنا عن الريزيستنس اكسرسايز، عن الويت بيرنج، عن الايروبيك اكسرسايز، ودور كل واحد فيهم ازاي بيعمل ستريس على البون ولودنج، واللودنج ده بيزود البالانس ان ريموديلنج. واتكلمنا عن الهول بودي فايبريشن، ان هو تكنيك بنستخدمه وان هو بيعمل اكسترا ميكانيكال ستيموليشن على الهول بودي. واتكلمنا عن الريسك فور فاكتورز فور فول in older people، ان في منها intrinsic وفي extrinsic، وان البرنامج لازم يكون متكامل مالتي فاكتوريال، لان اوريدي في فاكتورز كتير بتساهم في المشكلة، فبالتالي لما نيجي نحل بيكون البرنامج فيه كذا فاكتور وكذا ليفل للحل. طيب أنا كده خلصت المحاضرة، لو حد عنده أي سؤال أو حاجة اتفضلوا، إن شاء الله المحاضرة اللي جاية بعدي على طول. العفو، الله يعطيكم جميعا، يعافيكم، شكرا. العفو. ممكن طبعا حد بيسأل البون بين يكون من أهم السيمتومز، بس هو ريليتد أكتر بوقت الفراكشر بعد الالتئام. عادة الفراجيل فراكشرز بعد ما بيحصل لها التئام بيكون مصاحب ليها كرونيك بين. العفو، الله يعافيكم جميعا ويعطيكم العافية جميعا. لا، ما خلصتش المحاضرات، لسه في محاضرات تانية بعدية، محاضرتي بس أنا اللي خلصت، لكن إن شاء الله هتكملوا في محاضرات تانية بعدي. شكرا، شكرا أستاذ عمرو. الله يعافيكم جميعا.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. Welcome everybody. It's my pleasure to be with you today in this course related to calcium and bone disorders. We know that there is yearly we can say campaign day for osteoporosis, on the 20th of October every year. It is called World Osteoporosis Day. The Osteoporosis Day campaign yearly in this state to raise awareness about the bone diseases in general and specifically for osteoporosis disease. We know osteoporosis is important disease that harm a lot of patients, especially elderly female patients, plus other secondary causes for osteoporosis. In order to understand the pathophysiology, the basic physiology of calcium metabolism in our body and the disorder associated with it, it is important to discuss the basics. Then we'll go and go further about talk about calcium disorders and definitely talk about osteoporosis. So let's now start with the first physiology related to a calcium disorder. So the first slide here is to talk or to give overview, calcium definition and requirement, calcium metabolism regulator, like vitamin D, parathyroid hormone, calcitonin, function of calcium, calcium metabolic bone disease, calcium metabolism disorder. So what is calcium? The calcium is a mineral that is essential to bone health, cardiovascular health, muscle maintenance, circulatory health, and blood clotting. Calcium is also acting as enzyme activator, while calcium is found in milk and dairy products. It is also available from other food sources such as green leafy vegetables, seafood like, for example, salmon, with bone providers, and even greater dose, almond, blackstrap, mussels, broccoli, enriched soy and rice milk product, figs, beans, and tofu. This is a common question in the clinic or in daily practice. What are the food or what are the how we can increase our intake of calcium naturally? So the answer, as you can see here, is the calcium available in these products. Body requirement. What is the usual requirement of calcium? It is according to the age. If age between 1 to 3, calcium requirement is about 500 milligram, 4 to 8, 800 milligram, 9 to 18, 1,300 milligram, 19 to 50, 1,000 milligram, plus 51, 1,500 milligram. Usually pregnant and lactating female recommended a daily calcium intake of about 1,000 milligram also. Different forms of calcium at any one time. Most of calcium in the body exists as the mineral hydroxybutyrate. Calcium in the plasma, 45% in ionized form, the physiological active form, and this is the usually what we expect to have free calcium to do the jobs related to the calcium. 45% bound to protein, predominantly albumin, 10% complex with anion, citrate, sulfate, and phosphate. Usually in the practice, it is easy to calculate the total calcium, but you have to have a good calculation for correction with albumin. It is important to estimate the physiological level of ionized calcium in a state of hypoalbuminemia. So this is the equation used. Corrected calcium equal to measured calcium plus 0.8 multiplied by 4 minus the albumin in the serum. So please don't go for interpretation of any total calcium level in the chemistry of any patient unless you go for correction using this calculation or calculator equation to give the accurate calcium level. Regulating factors. It is regulated by parathyroid hormone and 125 hydroxy vitamin D on gut, kidney, and bone. Usually in the blood, we have inactive form of vitamin D, which is called 25 hydroxy vitamin D. This level, usually what we are measuring in the lab and depend on it while we are diagnosing and treating such a patient expected to have vitamin D insufficiency or deficiency. And some cases we are measuring the 125 hydroxy vitamin D, but the usual test recommended to identify patient with vitamin D deficiency is 25 hydroxy vitamin D. Usually, the definition of insufficiency between 20 and 30 nanogram, but if it is less than 20 or less than, sorry, 12, it is called severe deficiency. So between 12 and 30, we can say it is insufficiency, but less than 12, it is severe deficiency. The treatment usually will be discussed in separate lecture, but to give you an idea, deficiency or severe deficiency, less than 12, usually we are using, in adults, 50,000 unit of either ergocalciferol or cholecalciferol weekly for 6 to 8 weeks, and then you can give the maintenance 50,000 per month. Once you started the treatment, you have to measure the vitamin D 4 months after, or 3 to 4 months after, to make sure that you correct the vitamin D. Sometimes, in some cases of malabsorption, you may need to repeat the course, or you may increase the dose if there are if there is resistance to these first doses, therapeutic doses. So this is how to deal with vitamin D deficiency and insufficiency. One more issue to discuss while we are talking about calcium and vitamin D. It is very important to know that the inactive form vitamin of 25 hydroxy vitamin D need activation in the kidney under the effect of parathyroid hormone to active form 125 hydroxy vitamin D, which helps the absorption of calcium from the gut. So, two important factors play critical role in activation of inactive form of vitamin D to active form of vitamin D. Number one is normal renal function, kidney is working properly, and we have an intact parathyroid hormone. If the patient has renal impairment or renal failure, if the patient has hypoparathyroidism, patient will not develop or not convert the inactive form vitamin D into 125 hydroxy vitamin D, which is an active form of vitamin D, which help calcium to be absorbed from the gut. Two factors, again, important. what usually, if you have hypoparathyroidism and renal failure, you have to give vitamin D in active form, not the usual ergocalciferol and cholecalciferol. What is the active form? Usually we are giving what it is called calcitriol tablet or 1-alpha. This is another almost, we can say, active form that need conversion only in the liver to be active. So please, if you have renal failure, hypoparathyroidism, no benefit of cholecalciferol or ergocalciferol because they will not be converted into active form. Give in these two cases impairment, give full active form calcitriol immediately to cut the or to manage the case. Let's go further. Calcium receptors are present in parathyroid gland, kidney, brain, and other organs. As we mentioned before, the vitamin D metabolism, the active form of vitamin D, it is called 125 hydroxy vitamin D. It is production in the kidney by one of important enzyme called 1-alpha hydroxylase enzyme, and they need to be stimulated or regulated by parathyroid hormone level. So 1-alpha hydroxylase activity is usually increased by increased parathyroid level, decreased serum calcium, decreased serum phosphate. So what are the regulator of 1-hydroxy vitamin D, of 1-alpha hydroxylase activity to be active? If there is low calcium, it means we need more active vitamin D. So decrease serum calcium, will be corrected. Vitamin D inactive will be converted into active form, which helps the absorption of the calcium from the gut. What is the action of 125 hydroxy dihydroxy calciferol calcitriol? It increasing the intestinal or gut calcium absorption, as I told you before. So the calcium absorption will be calcium will be absorbed into bloodstream, goes in the bloodstream into bone, and the further work will be there, etc. Increase intestinal phosphate absorption, increase renal reabsorption of calcium and phosphate, as well increases resorption of bone. Let's talk now about the parathyroid hormone. The parathyroid hormone released, as we know, from the parathyroid glands. The parathyroid glands available or located in the thyroid glands. We have 4 parathyroid glands. It is a chemistry product. It is called 84 amino acid hormone, secreted from the chief cells of the parathyroid glands. Its function to increase renal phosphate excretion and increase plasma calcium by increasing osteoclast resorption of both, occurring rapidly, increasing intestinal absorption of calcium, slower response, increasing synthesis of 125 hydroxy vitamin D, stimulating the GIT absorption, and increasing renal tubular reabsorption of calcium. What are the regulation or regulators of parathyroid hormone? Low serum calcium, increased parathyroid secretion. High serum calcium, suppress parathyroid secretion. This is logic. If you have more calcium in the body, you don't need to have more calcium in the body. What will happen? There is parathyroid gland hormone suppression to decrease the conformation or converting the vitamin D, and ultimately decreasing calcium absorption. And the opposite is right as well. So please, if you have low calcium, there is normal response, low calcium increasing parathyroid gland hormones, and by this we convert more vitamin D from inactive form into active form, and by this way we have more calcium in the bloodstream. What about calcitonin? Calcitonin is produced by thyroid C cell. The function of it inhibition of osteoclast bone resorption, increasing the renal exacerbation of calcium and phosphate. Calcitonin, as you see here, calcitonin stimulates calcium salt deposit in the bone, and there is balance between or imbalance between the osteoclast and the we can say degrade bone matrix and release calcium into bone, and the parathyroid hormone released from the glands. So once falling blood level, the parathyroid gland will be stimulated, leading to parathyroid hormone release, osteoclast degrade bone matrix and release calcium, and calcium hemostasis of blood will be excreted and raising blood calcium level. So once we have low calcium or high calcium, this is the normal response from the body physiologically. Inhibiting factor, the amount of calcium consumed at one time can also affect absorption. In other words, calcium absorption decrease as the amount of calcium consumption increase in the meal, thus spreading consumption of calcium throughout your day is the best. We mentioned about the age requirement of calcium previously, so this is another factor to be considered in the clinical practice. Fiber, particularly from wheat bran, could also prevent calcium absorption because of its content of phytate, the dietary sodium, and protein increase calcium excretion as the amount of their intake is increased. Caffeine has a small effect on calcium absorption. It can temporarily increase calcium excretion and may modestly decrease calcium absorption. I think we'll share one of the videos here. So concentrate, please. Then we'll go back.
Hello guys, now in this video let's discuss about calcium homeostasis. See, parathyroid hormone PTH. Parathyroid hormone is getting produced from parathyroid glands. Now in the parathyroid glands the cells are called as the chief cells, and these chief cells are producing the parathyroid hormone. The important function of the parathyroid hormone is to increase the blood calcium levels. And which hormone decreases the blood calcium levels? This is a calcitonin. Okay, calcitonin, which is coming from the parafollicular cells of the thyroid gland. Parafollicular cells of thyroid gland are producing the calcitonin, which will decrease the blood levels of calcium. So we can say parathyroid hormone and calcitonin, they are antagonistic hormones. Okay, now let's see what are the functions of the parathyroid hormone. Wherever you see parathyroid hormone, it increases the blood calcium levels. How? See, whenever parathyroid hormone is released in pulsatile doses, okay, in a regular intervals. Now that pulsatile dose of parathyroid hormone will stimulate the osteoblasts and it will help in bone formation. But whenever you have the parathyroid hormone in a continuous doses, it stimulates osteoclasts, which will cause bone resorption. So it's all depend on whether the parathyroid hormone is coming in pulsatile doses or continuous doses. If there is continuous high levels of parathyroid hormone, then that parathyroid hormone will cause bone resorption or bone destruction. Pulsatile release, normal physiologically what happens is a pulsatile release. So whenever there is a pulsatile release, it stimulates osteoblasts, helps in bone formation. Let's see what are the functions of parathyroid hormone. When parathyroid hormone is acting on bone, what will happen in pulsatile doses? It stimulates the osteoblasts. When osteoblasts are stimulated, osteoclasts are going to produce something called as rank ligand. Okay, rank ligand. Now this rank ligand will act on osteoclasts. Now osteoclasts are activated. Now there will be bone resorption. Now whenever bone is getting resorbed, that will cause increased calcium levels. Guys, see, osteoclastic activity, it's under the control of osteoblasts. Okay, so parathyroid hormone first activates osteoblast, then osteoblast will produce rank ligand, and that rank ligand will activate osteoclast. So whether to activate osteoclast or not, it depends on osteoblasts. Okay, so whenever it's needed, bone resorption will happen, that increases the blood calcium levels. So what happens is, whenever you have parathyroid hormone in continuous doses, now osteoblasts will produce rank ligand. Okay, that activates osteoclast. But whenever the parathyroid hormone is released in pulsatile doses, then only osteoblasts are activated in such a way, only bone formation will happen. Continuous doses, high levels will activate osteoblasts in such a way, it produces rank ligand that activate osteoclasts, bone resorption happen, and blood calcium levels are increased. Okay, now parathyroid hormone will also act on the kidneys, that means it will also act on the nephrons. So parathyroid hormone increases the calcium reabsorption. It's not just absorption, it is reabsorption. Okay, reabsorption of calcium happens, and phosphates are excreted out of the body. Remember, parathyroid hormone PTH as phosphate trashing hormone. Parathyroid hormone trashes out the phosphate from the body. If phosphate and calcium are there in one place, they will attract each other. Calcium is plus and PO4 is minus. They will attract and they will form bonds, and they will precipitate as calcium phosphates. So if calcium phosphates are there, means like the ionic calcium levels are going down. So what parathyroid hormone wants to do is, it only wants to elevate calcium, it only wants free calcium. So to increases the free calcium levels, it takes out the phosphate from the body. So there is no one to come and attach with the calcium. So calcium stays in a free form, ionic form, which will increase the blood calcium levels or serum levels. Now the parathyroid hormone, it will also act on PCT of the nephron, and especially in the PCT of the nephron, there was this one important enzyme called as alpha-1 hydroxylase. When alpha-1 hydroxylase is activated because of parathyroid hormone, vitamin D activation will happen. What exactly is vitamin D activation? We know, we have already seen this. Conversion of 25 hydroxycholecalciferol into 1,25 dihydroxycholecalciferol with the help of alpha-1 hydroxylase happens in the proximal convoluted tubule, and that's also under the control of parathyroid hormone. So parathyroid hormone is the one actually controls the activity of alpha-1 hydroxylase. So whenever there is parathyroid hormone, alpha-1 hydroxylase is now working. Now it converts inactive vitamin D into active vitamin D, which is calcitriol or 1,25 dihydroxycholecalciferol. Now what this vitamin D will do? Vitamin D will go to the GIT mucosa. There in GIT mucosa, it increases both absorption of calcium as well as it increases the absorption of phosphates. Okay, also vitamin D acts on the nephrons, also increases the reabsorption of calcium. Now let's see a few important drugs which are used in the treatment of osteoporosis. Okay, this is something a pharmacological link. Guys, here I want you to know the first group of drugs to treat osteoporosis. What exactly is osteoporosis? Decrease in the bone mineral density. Bones are getting thinned out, bones are getting more reabsorbed, so the bone mineral density is getting decreased. So how we can treat this condition based on the concept whatever we have shared so far? See, bisphosphonates are the group of drugs which include salendronate, zoledronate, palmitoronate. Now these drugs, what is the mechanism of action? It's very simple. They will inhibit the osteoclast or causes the apoptosis of osteoclast. We know osteoclasts are the bone resorbing cells. So whenever you take out osteoclast, bone resorption is not happening. When bone resorption is not happening, that will treat osteoporosis, right? Either you have to increase the bone formation or you have to decrease the bone resorption. So bisphosphonates are the drug of choice for treating the osteoporosis. What they will do? They will inhibit the osteoclast. What are the drugs? Alendronate, ibandronate, pamidronate, zoledronate, all these drugs. The most important side effect is esophagitis and osteonecrosis of jaw. Especially while taking these drugs, they will cause esophageal irritation. Okay, you have to take these drugs with lot of water. You have to do like lot of hydration, and also you have to sit in upright position for the next 30 minutes. You should not, the patient should not lie down. That's a very important point to know. Okay, esophagitis, esophageal irritation, osteonecrosis of the jaw are the side effects. Now, let's talk one more drug which is called as raloxifene. Guys, raloxifene is nothing but a SERM. SERM means selective estrogen receptor modulator. You need to know something about estrogens. Estrogens are protective, bone protective, which means normally estrogens inhibit the osteoclast. Simple, remember it like this. Estrogens will inhibit the osteoclasts so that there is no bone resorption. Now, raloxifene is a kind of estrogen. Simple, it's acting like estrogen. Whenever it's acting like estrogen, it also inhibits osteoclasts so that there won't be bone resorption. If there is no bone resorption, osteoporosis is treated. Simple. Now, let's talk about teriparatide. What exactly is teriparatide? Teriparatide is a recombinant parathyroid hormone. Normally, parathyroid hormone is the one which acts on bone, causes bone resorption, increases the blood calcium levels. Then why we are using it in the treatment of osteoporosis? Because see, the concept is, yes, it is parathyroid hormone, but when you give in pulsatile doses, I have taught you, parathyroid hormone in pulsatile doses, it will stimulate the osteoblast, helps in bone formation. But parathyroid hormone in high concentrations and continuous doses will activate osteoclast, causes bone resorption. So teriparatide is one such hormone. Whenever you give it in pulsatile doses, it acts on osteoblast, helps in bone formation, treats osteoporosis. And the last group of drug, not last, but denosumab is a kind of drug. See, it's ending with the name MAB, monoclonal antibody. Now, yes, it's an antibody inactivating what? See, the denosumab, it's a monoclonal antibody, inhibits the rank ligand. What is this rank ligand? We just have seen. Osteoblasts, whenever they are continuously stimulated by parathyroid hormone, they are going to produce rank ligand which will activate osteoclast. So rank ligand is the one which activate the osteoclast. So what we are doing, we are producing an antibody which will go and attack the rank ligand. So rank ligand is taken out from the play. So whenever there is no rank ligand, osteoclast cannot be activated, bone resorption cannot happen, osteoporosis is treated. So it's a monoclonal antibody which is inhibiting the rank ligand given subcutaneously. And the last group of drug is the strontium renalate. Guys, this drug is very important because see, whatever the drugs which we have seen so far, either they have stimulated the osteoblast or they have inhibited the osteoclast. But the strontium renalate is a kind of drug which is having two hands. With one hand it is inhibiting the osteoclast, with other hand it is stimulating the osteoblast. Means both functions which are beneficial in treatment of osteoporosis. Okay guys, hope the video is helpful. See you in the next video.
So we try to summarize what I mentioned before in this video, and I hope it was clear. Let's go further now. What is the function? The function of calcium, it will help the body in muscle contraction, signal transmission, body structure as well. So the deficiency of calcium level in the body may induce several diseases like rickets, for example, which is usually seen in the children, adult osteomalacia, and osteoporosis. So this is the usual diseases related to calcium disorder. Rickets, usually it is a softening of bone in children, potentially leading to fracture and deformity. The predominant cause is a vitamin D deficiency. Lack calcium in the diet may also lead to rickets. This is number one. Number two, osteomalacia is the softening of the bone due to defective bone mineralization. It may show signs as diffuse body pain, fragility of the bone, A common cause of the disease is deficiency in vitamin D, which is normally obtained from the diet and sunlight exposure as well. This is the usual clinical manifestation, clinical picture with deviated legs seen in such a case. Osteoporosis, the main disease characterized by low bone mass and structural deterioration of bone tissue, leading to bone fragility and increased risk of fracture of the hip, spine, and wrist, leading to bone fragility. Men as well as women are affected by osteoporosis. Women had high rate to be affected by osteoporosis. I think again we have a quick video for a quick review. Please concentrate.
Calcium homeostasis. How is it regulated? Calcium is important for many bodily functions. It's mainly required for forming biomaterial for bones and teeth, existing primarily as bound calcium. For all other physiological functions, calcium is required in its free ionic form. Ionic calcium is involved, for example, in forming action potentials, in the cross-bridge cycle in muscle contraction, in cell division, as factor 4 in secondary hemostasis, and as a neurotransmitter and second messenger in cell communication. Because of its many roles, the total amount and distribution of calcium in the body is strongly regulated. Let's look at this in further detail. Under physiological conditions, calcium is absorbed from the intestine and excreted via the kidneys. The majority of calcium, approximately 99%, is stored in the body as calcium phosphate in bones and teeth. Around 1% of total body calcium is extracellular, whereas approximately 0.01% is intracellular. In cells, calcium is stored in cell organelles, such as the mitochondria and the endoplasmic reticulum, keeping the cell cytoplasm basically free of calcium. Extracellular calcium is transported throughout the body via the blood vessels. Two primary factors are responsible for stabilizing blood calcium levels. The parathyroid hormone, in short PTH, which forms in the parathyroid glands, and vitamin D, which is synthesized in the liver and skin and converted into its active form, calcitriol, in the kidney. A third regulator is calcitonin, which forms in the thyroid gland, though its physiological significance in regulating calcium homeostasis is likely relatively low. This assumption derives from the fact that calcitonin doesn't need to be substituted in an underactive thyroid to maintain calcium levels. However, later on in this episode, we'll see that it still plays a role in regulating blood calcium levels. Vitamin D facilitates the absorption of calcium and phosphate from food in the gastrointestinal tract, maintaining their blood levels. This activates osteoblasts and consequently mineralization as well as bone remodeling. In the kidney, vitamin D ensures the resorption of calcium and phosphate, however, for the latter, only in the presence of PTH. Now, PTH also stabilizes blood calcium levels, primarily by activating osteoclasts and therefore bone demineralization. Consequently, this causes the release of calcium and phosphate. Since phosphate is an alkaline anion, an increased release needs to be compensated for by increasing the excretion of alkaline anions, such as phosphate and bicarbonate, via the kidneys. Accordingly, PTH decreases phosphate resorption. At the same time, it facilitates calcium resorption in the kidneys. As a result, differing amounts of calcium and phosphate are resorbed. If both amounts were equal, phosphate would bind directly to the calcium ions, thereby preventing an increase in free ionic calcium. PTH only indirectly affects absorption in the gastrointestinal tract by facilitating the production of active vitamin D. So, in summary, vitamin D elevates the amount of calcium and phosphate in the blood, while PTH also increases calcium levels but decreases those of phosphate. The body registers whether the right amount of extracellular calcium is present using calcium-sensitive receptors. These are located primarily in renal tubular cells and the parathyroid gland. If there's an increase in serum calcium, for example in hypercalcemia, this inhibits PTH secretion but stimulates the release of calcitonin. In turn, calcitonin ensures that less calcium is absorbed from food. Also, it inhibits osteoclast activity and therefore the release of calcium and phosphate from the bones and facilitates their excretion via the kidneys. Therefore, calcitonin can lower calcium and phosphate blood levels. This is why it's also used as a therapeutic agent in hypercalcemia. In contrast, if there's a decrease in serum calcium, for example, in hypocalcemia, this stimulates PTH secretion. In addition, vitamin D then facilitates osteoclast activity, which in turn increases the release of calcium and phosphate from the bones. Consequently, blood calcium levels increase again. Needless to say, despite these regulatory mechanisms, calcium imbalances can occur. Now, let's check out the quiz on the next slide.
Welcome. This video is going to cover calcium homeostasis. So calcium levels in the body, especially in the blood and in the extracellular spaces around our cells, is critically important. So it needs to be maintained for our body to function. Somewhere between 8 and 10 milligrams per deciliter is considered normal blood calcium. So if the calcium levels in your blood ever drop to a critically low level, the body's going to need to respond. Now you might think of calcium as needed for your bones, but actually calcium is critically important for function of the brain and the heart. Little cardiac myocytes and neurons need calcium in order to have action potentials, to contract, and in order to release neurotransmitter. Even your skeletal myocytes in your muscles need calcium in order to function. So whenever calcium gets too low, how does the body regulate it and increase it back towards normal? It's actually the cells of the parathyroid glands located in the neck that are responsible for calcium regulation. They're actually found embedded in 4 little clumps on the thyroid gland. And these parathyroid gland cells have a special little calcium sensitive receptor which can sense the levels of calcium in the extracellular fluid. As blood calcium levels get low, these cells release more PTH through exocytosis. The parathyroid hormone then travels throughout the body, targeting various tissues. One of the primary targets of PTH will be the bones. So the little cells in bone are either building bone or chewing up the bone. You might remember osteoclasts and osteoblasts. Osteoblasts will build bone and osteoclasts chew up the bone. In the case of PTH signaling, the osteoblasts will become less active. The osteoclasts will become more active. This will release stored up calcium from the bone into the bloodstream, which will help increase blood calcium. Again, PTH changes the activity of these bone chewing and bone building cells so that more calcium is released from the bone matrix into the bloodstream, helping raise blood calcium levels. Another important target of PTH will be the kidneys. The kidneys are responsible for filtering things in blood, and then it can remove those from the body in urine. So since calcium's in your blood and calcium's very small, it easily filters into the kidneys. The kidney cells then must reabsorb the calcium and keep the calcium in the body. PTH is critically important to tell those cells to keep the calcium that is filtered. So as PTH levels go up, the little kidney cells know to keep more calcium, in essence reabsorbing it, adding it back to the bloodstream, and helping raise and keep our blood calcium levels high enough. So whenever PTH levels are high, the kidneys are reabsorbing more calcium, and less calcium ever makes it into the urine, and so the urine would have low calcium levels. Another important target for PTH is going to be the intestines. Since we get a little bit of calcium usually from our digested food, the intestines become an important source for blood calcium. So as food is digested inside the intestines, the calcium is released, then the calcium has to be absorbed by the little intestinal cells. Otherwise, it ends up going out of the body in the feces. So PTH signals to those little intestinal cells to get the calcium from the digested food and absorb it into the body. This then adds the calcium to the bloodstream and helps raise calcium levels in the body. An important thing to know about PTH signaling in the intestines is it requires the help of vitamin D. You might think of vitamin D as something that comes from sunlight and your skin, and you'd be right. But vitamin D actually is activated in the kidneys to a hormone called calcitriol. And as PTH levels go up, the kidneys make more calcitriol from vitamin D, and this means that as PTH goes up, calcitriol goes up, and it's actually calcitriol acting on the intestines to tell the intestinal cells to get that calcium. So just remember, vitamin D and PTH are important for the intestines. So remember, whenever calcium levels get low, the parathyroid glands are going to broadcast PTH signal, which will help our bones know to release calcium, our kidneys to reabsorb calcium, and our intestines to absorb calcium from our diet. This helps bring our blood calcium levels back up to normal, maintaining homeostasis.
Okay, I am done with this basic physiology about calcium, how to deal with it. So please, before I proceed or go for the next topic, I need your questions. If you have any, please, we'll give 2 minutes for your questions. I'm waiting your questions down in the chat box or in Q&A. Usually what I received is the differences, or the question that I usually receive is what is the difference or differences between vitamin D, 25 hydroxyvitamin D, and the active form, which is 125 hydroxyvitamin D. So please, the conversion need presence of two important factors, as I told you before, the normal kidney function test and intact parathyroid gland. So please, this is a very important to know. If you have patient with renal failure or hypoparathyroidism, don't give inactive form. You need to give the active form to overcome this missing conversion, and definitely by this way you will get the active form, which is calcitriol, which helps the absorption of calcium and regulate normal hemostasis of bone. I think if you have no questions, I will give you 10 minutes break only. 10 minutes break only. So it is now 4:45. We'll be back for 55. So back at 4:55. 10 minutes only, just for refreshment. 10 minutes, please. Let's go again to the calcium diseases. We have two main disorders related to calcium. definitely the increase in calcium level, which is called hypercalcemia, and decreased calcium level, which is hypocalcemia. The part which I will talk about is hypercalcemia, high calcium level, and other colleagues will talk about hypocalcemia in the subsequent lectures in the coming few days. And I hope that you identify the clinical presentation, causes, investigation needed, and how to treat these cases because they are unfortunately sometimes missing in the clinical practice. So I will start with hypercalcemia with no further delay. Hypercalcemia is a condition in which the calcium level in the body is above the normal. The need of calcium for the bone formation and muscle contraction releasing hormone. The main cause is overactivity of the parathyroid gland. Cancer and some medication may cause over the activity of this calcium level. Etiology of hypercalcemia. What is the causes or what are the causes of hypercalcemia? 90% of cases are due to primary hyperparathyroidism or malignancy. So please, if you find high calcium level, you put in your mind that outpatient department, usually the main cause or the most important cause is hyperparathyroidism, while during hospitalization, the most common cause of hypercalcemia is malignancy. Again, this is a multiple choice question in the clinical or in the clinical examination, yes, written examination. What is the most common cause of hypercalcemia in inpatient setting and in outpatient setting? In outpatient setting, hyperparathyroidism is the answer, and in inpatient setting, the malignancy is your answer. So hyperparathyroidism, high parathyroid hormone leading to hypercalcemia, usually mild within 1 milligram above limit of normal and associated with elevated parathyroid hormone level, may be asymptomatic or show signs of chronic hypercalcemia, for example, nephrolithiasis. So please, if the patient presented with renal stone, it is very important to know that maybe there is underlying cause like hypercalcemia, or hyperparathyroidism. Don't pass it easily. Maybe nephrolithiasis or renal stone is due to hypercalcemia or hyperparathyroidism. Malignant disease. Usually, patient is ill, parathyroid level usually low, parathyroid-related peptide often is elevated. So this is how to deal with cases related to hypercalcemia. You have to keep in your mind that maybe patient presented with critically ill hypercalcemia, and this is usually seen in malignancy, and in cases of mild hypercalcemia or less severe hypercalcemia, maybe you expect primary hyperpara, but again, you may see cases with high calcium, very high calcium with hyperparathyroidism. So it is not a cut point, but we are saying here about the top differential diagnosis. Less common causes of hypercalcemia may include thyrotoxicosis, adrenal insufficiency, granulomatous diseases, medication, and renal failure. What are the clinical manifestations that is usually, or what that are usually observed in cases of hypercalcemia. Mild hypercalcemia is usually asymptomatic. So this is number one. Mild hypercalcemia above normal is upper normal, for example, is 2.1 or 10.1 or 10.2. Patient with up to, for example, 11 or 12, maybe it is considered mild hypercalcemia. And in these cases, patient maybe has mild symptoms or maybe has no symptoms. Moderate to severe hypercalcemia above 12 or severe above 14 may present with GIT or gastrointestinal symptoms like, for example, nausea, vomiting, constipation, pancreatitis, renal renal symptoms like polyuria, polydipsia, nephrogenic DI or diabetes insipidus, nephrolithiasis, neuromuscular like depression, confusion, coma, muscle weakness, cardiovascular like short QT interval, hypertension, AV block, and others like shock and death may be observed. I think I have video here to summarize what we are talking about. Please concentrate and then I will be back to you.
With hypercalcemia, hyper means over and cal refers to calcium, and emia refers to the blood. So hypercalcemia means higher than normal calcium levels in the blood, generally over 10.5 milligrams per deciliter. Now, calcium exists as an ion with a double positive charge, Ca2+, and it's the most abundant metal in the human body. So I know what you're thinking. Yeah, we're all pretty much cyborgs. Anyways, about 99% of that calcium is in our bones in the form of calcium phosphate, also called hydroxyapatite. The last 1% is split so that the majority, about 0.99%, is extracellular, which means in the blood and in the interstitial space between cells, whereas 0.01% is intracellular, or inside cells. High levels of intracellular calcium causes cells to die. In fact, that's exactly what happens during apoptosis, also known as programmed cell death. For that reason, cells end up using a ton of energy just to keep their intracellular calcium levels low. Now, calcium gets into the cell through two types of channels, or cell doors, within the cell membrane. The first type are ligand-gated channels, which are what most cells use to let calcium in, and are primarily controlled by hormones or neurotransmitters. The second type are voltage-gated channels, which are mostly found in muscle and nerve cells and are primarily controlled by changes in the electrical membrane potential. So calcium flows in through these channels, and to prevent calcium levels from getting too high, cells kick excess calcium right back out with ATP-dependent calcium pumps, as well as sodium-calcium exchangers. In addition, most of the intracellular calcium is stored within organelles like the mitochondria and the smooth endoplasmic reticulum, and is released selectively just when it's needed. Now, the majority of the extracellular calcium, the calcium in the blood and the interstitium, is split almost equally between two groups: calcium that's diffusible and calcium that's not diffusible. Diffusible calcium is separated into two subcategories: free ionized calcium, which is involved in all sorts of cellular processes like neuronal action potentials, contraction of skeletal, smooth, and cardiac muscle, hormone secretion, and blood coagulation, all of which are tightly regulated by enzymes and hormones. The other category is complex calcium, which is where the positively charged calcium is ionically linked to tiny negatively charged molecules, like oxalate, which is a small anion that's normally found in our blood in small amounts. The complex calcium forms a molecule that's electrically neutral, but unlike free ionized calcium, it's not useful for cellular processes. Both of these are called diffusible because they're small enough to diffuse across cell membranes. Finally, though, there's non-diffusible calcium, which is bound to negatively charged proteins like albumin. and the resulting protein-calcium complex is too large and charged to cross membranes, leaving this calcium also uninvolved in cellular processes. When the body's levels of extracellular calcium change, it's detected by a surface receptor in parathyroid cells called the calcium sensing receptor. This affects the amount of parathyroid hormone that gets released by the parathyroid gland. The parathyroid hormone gets the bones to release calcium and gets the kidneys to reabsorb more calcium so it's not lost in the urine, as well as synthesize calcitriol, also known as active vitamin D. Active vitamin D then goes on to cause the gastrointestinal tract to increase calcium absorption. Altogether, these effects help to keep the extracellular levels of calcium within a very narrow range, between 8.5 to 10 milligrams per deciliter. Sometimes, though, total calcium levels in the blood, which includes diffusible and non-diffusible, can vary a bit, depending on the blood's pH and protein levels. This happens because albumin has acidic amino acids, like glutamate and aspartate, and these have carboxyl groups that are in the form of COO- or COOH. Overall, the balance of COO- and COOH changes based on the pH of the blood. Now, when there's a low blood pH, or acidosis, there are lots of protons, or H+ ions, floating around. And a lot of those COO- groups pick up a proton and become COOH. More COOH groups means that albumin generally becomes more positively charged. And since calcium's positively charged, these two repel each other. And this decreases bound calcium and increases the proportion of free ionized calcium in the blood. So as more protons bind albumin, more free ionized calcium builds up in the blood. And so even though total levels of calcium are the same, there's less bound calcium and more ionized calcium, which remember is important for cellular processes, meaning that this can lead to symptoms of hypercalcemia. Also, though, any condition that results in hyperalbuminemia or high albumin levels causes there to be a higher concentration of protein-bound calcium, while free ionized calcium concentrations stay essentially the same due to hormonal regulation. This is therefore called false hypercalcemia or pseudo-hypercalcemia, since the concentration of bound calcium increases, but the concentration of free ionized calcium stays the same. Even though this is rare, it can happen in people with dehydration, where albumin gets really concentrated. Now, true hypercalcemia might be caused by increased osteoclastic bone resorption, which is actually the most common cause. And this is where osteoclasts, which are little bone-eating cells, frantically break down the bone and release calcium into the blood. This might happen when the parathyroid gland becomes overgrown and releases more parathyroid hormone. Another well-known cause of hypercalcemia are malignant tumors, some of which secrete parathyroid hormone-related protein, or PTHrP, a hormone that mimics the effect of parathyroid hormone, which stimulates the osteoclasts. Alongside these osteoclast cells, there are also osteoblast cells, which are bone-building cells, and some tumors cause osteoblasts to die off. Overstimulated osteoclasts without enough osteoblasts can result in lytic bone lesions, which are commonly seen in some malignancies. Another cause of hypercalcemia is excess vitamin D, either through the diet or through supplements, which can cause there to be too much calcium absorbed in the gut. Finally, there are some medications, like thiazide diuretics, which increases calcium reabsorption in the distal tubule of the kidney, which contributes to hypercalcemia. High levels of ionized calcium affect a variety of cellular processes, in particular electrically active neurons. Normally, calcium ions stabilize the resting state of the sodium channels, which prevents them from spontaneously opening and letting sodium ions enter the cell. With high levels of extracellular calcium, voltage-gated sodium channels are less likely to open up, which makes it harder to reach depolarization and makes the neuron less excitable. And this is what causes slower or absent reflexes, which is a classic symptom of hypercalcemia. The sluggish firing of neurons also leads to slower muscle contraction, which causes constipation and generalized muscle weakness. In the central nervous system, hypercalcemia causes confusion, hallucinations, and stupor. In most cases, when there's too much calcium in the blood, the kidneys try to dump it into the urine, causing hypercalciuria, or excess calcium in the urine. Hypercalciuria leads to a loss of excess fluid in the kidneys, causing an individual to get dehydrated. And the combination of hypercalciuria and dehydration can lead to calcium oxalate kidney stones. Hypercalcemia is diagnosed based on high levels of calcium in the blood, generally above 10.5 milligrams per deciliter. An electrocardiogram might show changes like bradycardia, AV block, shortening of the QT interval, and sometimes in the precordial leads the appearance of an Osborn wave. To identify the cause, lab tests are typically done, looking at parathyroid hormone, vitamin D, albumin, phosphorus, and magnesium levels. In hypercalcemia, the main goal is to lower calcium levels using medications that reduce calcium in the blood. One approach is to increase urinary excretion of calcium, which can be done by rehydrating an individual, which causes more calcium to get filtered out. In addition, loop diuretics can be helpful because they inhibit calcium reabsorption in the loop of Henle, leaving calcium in the lumen of the nephron to get excreted. Another approach is to increase gastrointestinal excretion by using glucocorticoids to decrease intestinal calcium absorption, which allows it to instead simply pass through the gut without getting absorbed. Finally, you can prevent bone resorption by using biphosphonates or calcitonin to inhibit osteoclasts. Alright, as a quick recap, hypercalcemia describes a high concentration of free ionized calcium in the blood, which most commonly results from excess parathyroid hormone, as well as malignancies. High calcium levels cause excitable cells to be less excitable, which results in slow reflexes, muscle weakness, and constipation. What's going on?
So we talked about here, summarize the clinical manifestation, how to pick up the ECG finding, to identify the hypercalcemia. Now it's the time to talk about management of hypercalcemia. Usually we have to identify the underlying cause. So treat underlying cause if possible. Discontinue medication that may exacerbate the problem. Mobilize patient as soon as possible. Give saline hydration. Give loop diuretic if hypercalcemia is severe or patient has compromised cardiac or renal failure. Use only after extracellular fluid volume has been restored. Calcitonin, if rapid onset of action is desired, intravenous bisphosphonate, glucocorticoid, or dialysis can sometimes be indicated. I have a question here for you, and please, if you can participate down in the chat box. I have a scenario of 81-year-old man presented in emergency department for altered mental status. He was found at home, confused, lethargic. Past medical history is significant for metastatic prostate carcinoma. On examination, blood pressure 110/50, pulse 110, lethargic, minimally responsive to sternal rub, has bitemporal wasting, has mucous membrane dry, patient has intact gag reflex, and withdraw to pain in all four extremities. Laboratory significant for high creatinine level, 4.2 milligram per deciliter. Calcium level is 14.7, hypercalcemia, milligram per deciliter. Albumin is 2.3. So the question here, all the following are appropriate initial management step except. So we are talking about hypercalcemia management here. I want you to choose the wrong item. A. Normal saline. B. Bamidronate. C. Calcitonin. D. Dexamethasone. I'm waiting your responses. I will give you a few seconds. So please choose the wrong answer. I will discuss with you this scenario. This is our approach, how to deal with treatment of hypercalcemia. So in case-based discussion, this is a real clinical scenario, and we can go further. So if you see your answers, a variety, actually, I cannot say that maybe the B is the highest number or highest choice, sorry. But still we have A and we have C. Let's go further now. Answer actually is D, dexamethasone. So what is the key message behind this question? Hypercalcemia is a common oncological complication of metastatic carcinoma, regardless of underlying disease. The treatment is usually similar. Symptoms usually including confusion, lethargy, change in mental status, fatigue, polyuria, constipation, nausea, and vomiting. Patient with severe hypercalcemia identified with serum calcium level above 14 milligram per deciliter or 3.5 millimole per liter, or symptomatic hypercalcemia, usually dehydrated, and require saline hydration as initial therapy. Severe hypercalcemia, particularly if it is developed acutely, may lead to lethargy, stuporness, and coma status. Usually, the fluid replacement is a reasonable regimen to be given as isotonic saline at initial rate of 200 to 300 ml per hour. That is then adjusted to maintain the urine output at 1 to 150 ml per hour. These patients are often dehydrated as hypercalcemia may cause nephrogenic diabetes insipidus and are often unable to take fluid orally. Therefore, the primary management entails re-establishment of eovolemia. This is your goal. Restore the eovolemic status first. Often, hypercalcemia will resolve with hydration alone. It is not routinely recommended to add loop diuretic from the beginning, but as we mentioned before, in some cases, like for example, heart failure, renal failure, or renal insufficiency, maybe you can give loop diuretic if there is a decompensation. Plus, you have to go for careful monitoring and good judgment of loop diuretic required if patient is overloaded. So this is number one management about fluid. Bisphosphonate is number two. Any role of bisphosphonate in acute hypercalcemia? Yes, it stabilizes osteoclast resorption of the calcium from the bone. Its effect may take 1 to 2 days to manifest. Care must be taken in cases of renal insufficiency, as rapid administration of bamidronate or other zoledronic acid may exacerbate renal failure. Nasal or subcutaneous calcitonin aid the shift of calcium out from intravenous space. Steroid glucocorticoid may be useful in patients with some cases. This is the key here in this question. The question was about management of hypercalcemia in patients with prostatic carcinoma. Should we give steroid in such a case? The answer, as you see here in this slide, it is effective to give steroid in management of hypercalcemia in some malignant cases, like lymphoid malignancy, sarcoidosis, or other granulomatous diseases, as the mechanism of hypercalcemia in those conditions is often related to excess hydroxylation of vitamin D. So, if the underlying cause of hypercalcemia is excess hydroxylation of vitamin D leading to hypercalcemia, please use steroid. But in patient with prostatic carcinoma, this is not this mechanism is not there. There is no rule for steroid. So the exception was steroid use in management of hypercalcemia in such a case. There is increased conversion of 25 hydroxy vitamin D to the potent of 125 hydroxy vitamin D, enhances intestinal calcium absorption, resulting in hypercalcemia and suppressed parathyroid hormone. So glucocorticoid decrease 125 hydroxy vitamin D production. Zoledronic acid or Zometa can be used. This is the usual bisphosphonate of choice, easily available in our hospitals. Dose is about 4 milligram, 15 to 30 minutes in 100 ml saline. Side effect expected with this medication, including flu-like symptoms, 30% of patients, hypocalcemia, so you have to have a normal vitamin D level, and please, you have to monitor your patient after that. Other bisphosphonate available in the market, like pamindronate, can be used. Ibandronate, again, can be used. What about calcitonin? Calcitonin usually given subcutaneously every 2 hours for the first 2 days only. Why? And what is the mechanism? The mechanism of action of calcitonin. It inhibits bone resorption via interference with osteoclast function, promote urinary calcium excretion for the first 48 hours. After 48 hours, there is tachyphylaxis effect. The receptor of this medication is not anymore accepting the medication, so it is useless to use this medication after 48 hours due to tachyphylaxis effect associated with the receptors. Bisphosphonate usually duration of action 2 to 4 weeks, maybe sometimes it is useful to give another dose of zoledronic acid after 3 to 4 weeks if patient develop hypercalcemia again in resistant cases. Loop diuretic, as we mentioned before, can be given in some cases, like, for example, patient with heart failure. Steroid decreases intestinal calcium absorption, decreases 125 hydroxy vitamin D production by activated mononuclear cells in patient with granulomatous disease or lymphoma. Duration or onset of action usually 2 to 5 days, and duration of action days to weeks. Denosumab again can be given. It inhibits bone resorption via inhibition of Rankin L, as we mentioned before. 4 to 10 days is the action, and duration of action 4 to 15 weeks. I did not mention fluid, the mechanism of action, restoration of intravascular volume, increase urinary calcium excretion, and onset of action is usually hours. Sometimes we use calcimimetic calcium sensor receptor agonist. It reduces parathyroid hormone in cases of parathyroid carcinoma. Dialysis, if there is resistant of hypercalcemia, can be considered. So we talked about the scenario here, but if the patient presented to you with less severe hypercalcemia or with asymptomatic or mildly symptomatic hypercalcemia, calcium level less than 12 or less than 3 millimole, usually what is the usual primary tool or treatment here is avoiding factors that can aggravate hypercalcemia, including thiazide diuretic, lithium carbonate therapy, volume depletion, prolonged bed rest, or inactivity, vitamin D supplementation, high calcium diet, more than 1000 milligrams per day. Asymptomatic or mildly symptomatic individuals with chronic moderate hypercalcemia, calcium between 12 to 14, which is between 3 to 3.5, may not require immediate therapy, but if there is an acute elevation to this level may cause GIT side effect and changes in the sensorium and may require treatment like severe hypercalcemia. طيب, I will go to this question and I need your participation. The most common cause of high serum calcium in patients with known carcinoma is A. Ectopic production of parathyroid hormone, B. Direct destruction of bone by tumor cells, C. Local production of tumor necrosis factor and interleukin 6 by bone metastasis, D. High level of 125 hydroxyvitamin D, E. Production of parathyroid hormone-like substance. I need to receive your answers, please, in the chat box. Let's see your answers. We have different ideas or different opinions between C and E, and some of you going with A. Let's see the correct answer and the idea behind it. Answer E is the correct answer. Although it was thought that commonest cause is direct resorption of bone by tumor, it is now recognized that 80% of such instances occur because of the production of protein called parathyroid hormone-like peptide by the tumor. So the most common factor that play a role is parathyroid-related peptide. Parathyroid-related peptide functionally identical to native parathyroid hormone in that it causes renal calcium conservation, osteoclast activation, and bone resorption, renal phosphate wasting. Squamous cell carcinoma of the lung is the most common tumor associated with production of parathyroid-related peptide. So this is again a common written question, exam question. What is the commonest cause of hypercalcemia related to parathyroid related peptide, squamous cell carcinoma, and hypercalcemia? Only 20% of cases of hypercalcemia malignancy are due to local production of substance such as transforming growth factor and interleukin 1 and interleukin 6, which cause bone resorption at local level and release of calcium from body store. This is how to deal with hypercalcemia in the clinical practice. If you see a patient with hypercalcemia, next step is to measure parathyroid hormone. If it is elevated or mildly elevated to normal, consider parathyroid-related peptide. Consider either one of the following differential diagnoses. If 24-hour urine collection of calcium is high, above 200 milligram per 24 hours, you are dealing with primary hyperparathyroidism. Consider surgery in some cases. Measure BMD, refer for surgery or monitoring. If the patient has low calcium, 24-hour urine collection, less than 100, consider familial hypercalcemic hypercalciuria. Hypercalcemic hypocalciuria is the cause. Before I leave this point, it is very important to know that there are some indications in primary hyperparathyroidism in which you push patient for surgery. Not all cases need surgery. Not all cases of hyperparathyroidism need surgery, but the indications usually age less than 50, 24-hour urine collection is high, calcium level in serum 1 milligram above the normal, there is decrease in GFR or glomerular filtration rate, there is symptoms of, or there are symptoms of hypercalcemia. So also, if there is osteoporosis, T-score minus 2.5 and less. So if you find these items or these, we can say, points, push the patient into surgery. Otherwise, maybe you can monitor your patient frequently. In the other side, if the parathyroid hormone less than 20, it is consistent with non-parathyroid mediated hypercalcemia, and you have to measure parathyroid-related peptide and vitamin D. So if the parathyroid-related peptide is elevated, consider malignancy scanning. If elevated 1-hydroxyvitamin D is there, consider causes like lymphoma and sarcoid, doing chest X-ray to identify these cases. If there is normal vitamin D, normal parathyroid-related peptide, consider other causes, measure vitamin A, TSH, elevated 25-hydroxy, vitamin D, check medication, vitamin herbal supplementation, which should be considered. So by discussing the approach of hypercalcemia differential diagnosis, I will leave you here and we'll discuss the details of causes of hypercalcemia in the coming few days later on in this course. I think it's the time to leave you today. My part is done. My colleague will resume the lectures with you at 6 p.m. And we'll leave you to go for a prayer break. So please go for prayer break for about 25 minutes and be right back sharp at 6 p.m. to resume the other parts remaining in today's lectures. I hope it was interesting for all of you and you got the benefit. Hope to see you again soon in the coming lectures during this course. Goodbye for everyone. So I will put you the announcement for a reminder, 6 break till 6 p.m.
disorders in relationship to vitamin D deficiency. So for our first topic is the risk factors for osteoporosis. As you know, osteoporosis is one of the more common calcium-related disorders that can impact our health, and we can perhaps prevent it with appropriate interventions such as nutritional intervention. So first of all, we need to understand what is osteoporosis. It's a term used for diseases or diverse etiology that causes a reduction in the mass of the bones per unit volume. There are also other types which include osteomalacia, in which the mineralization of the organic matrix is defective in these individuals. And in most cases, we can find some sections of the bones that shows osteoporosis, as the one in the picture, as you can see, is a conversion between a normal bone development and osteoporotic bone shape or lesions. So it will lead to reductions in the mass of the bone per a unit of volume. So osteoporosis is classified based on many factors, but the most common forms are unassociated with other diseases. The first one is the idiopathic, the juvenile and adult type. There is also type 1 and type 2 osteoporosis. Also, there are conditions in which osteoporosis is a common feature. This can include most endocrine disease, such as thyrotoxosis, hyperadrenocortism, scurvy, malabsorption, hypogonadism, calcium deficiency, and other systematic metacrosis and other type of disorders. Also, osteoporosis can be a feature of heritable disorders of the connective tissue. These include the osteogenesis imperfecta, the homocystinuria, and other type of inborn error of metabolic disease. In addition, there are disorders in which osteoporosis is associated, but the pathogenesis is not well understood in most cases. These can include rheumatoid arthritis, malnutrition, alcoholism, epilepsy, in addition to diabetes, COPD, and Menkes disease in some cases. So osteoporosis is a very prevalent disorder. In America alone, about 10 million, 80% women and 20% men will have osteoporosis. And this is estimated about 44 million more will have low bone mass and will be at the risk of developing osteoporosis. So about half of the women and 1/4 of men over the age 50 will have an osteoporosis-related fracture in their lifetime. So as you can understand, it's a very, very common problem or health disorder. So in the US alone, it can cause more than 1.5 million fractures each year in the US alone. And about 150,000 hospitalizations per year for the medical management of spinal fractures are related to osteoporosis, all of which can indicate how prevalent this problem is. Also, it can have some economical cost as well due to the high value of their care in the hospitalization, and this will be projected to increase to over 60 billion in 2030. So the physiology of the osteoclast is that large motivated factors can contribute. These are often derived from peritoneal cells that are similar to the macrophage, but can differ in the production of the tartar-resistant acid phosphatase. So the inactive or the resting will be stimulated by the rank lesion, the rank L, and therefore the control of the osteoclast as well as the bone homeostasis is very complex. These involve mechanical factors, immunological factors, as well as hormonal, neurological, and metabolic factors as well. So the activated cells will bind to the bone through the cell attachment protein that is called intergenes. So the cells will become polarized, will have ruffled borders that appear in the field zone. And therefore, the pH that is lowered by the production of the H ions from the carbonated anhydrase system, which will dissolve the HA crystals and therefore remove the organic matrix through proteolytic digestion. So this is an illustration of the process in which the osteoclast can develop. So the pathophysiology includes an estrogen deficient, mechanical or tobacco or steroid factors. All of these can lead to osteoporosis. So the cancerous bones will be remolded at 30% or 30 years, with the cortical bone about 30 years, with the surface area phenomenon. And women will lose the spinal bone at about 2 to 4 years immediately after menopause, which increases their risk of developing osteoporosis. Also, tobacco is related to the risk of developing osteoporosis, as impaired osteoblast metabolism is due to tobacco use. So, breaking down the products that are toxic to the oblast through the DNA and RNA, in addition to the protein synthesis and the toxic free radical injury. And these free radicals will cause cellular membrane injury via the lipid peroxidation. So as a result, a protective effect of estrogen will be negated, and the hepatic metabolism and the hydroxy inactivation of the estrogen will be accelerated. So in women, early menopause and resistance to exogenous hormone replacement is common. With tobacco even use, this can put them at an increased risk and will induce the calcitonin resistance in general. So this is the mechanical loading of the tobacco effect on the cellular factors that will lead to osteoporosis. So in addition to this, the steroid-induced osteoporosis is the most common cause of the drug-induced osteoporosis. Therefore, the calcium absorption from the gut will be reduced and the urinary calcium excretion will be increased. So the abundant casus of the endoblast of the collapsed vertebra are a strong indicator of the corticosteroid-induced osteoporosis in these cases. So in the steroid-induced osteoporosis, the bones loss will begin immediately and greatest in the first year during steroid use. This will be corresponding to an average 5% loss of the bone mass. So a significant trabecular bone loss with doses of prednisone, including inhaled doses, are greater than 7.5 milligram per day will accelerate or increase the risk. So increased risk of vertebral and as well as hip fracture, even with dose equivalent to 2.5 or up to 7, will also play a role in these factors. So about 30 to 50% of patients who undergo corticosteroid therapy will sustain a fracture. And the fracture risk is up to 15% during the first year of treatment with steroids. So the corticosteroid will raise the fracture risk for up to 6-fold across all ages, regardless of the bone mass before the steroid treatment. So calcium and vitamin D should be offered to all patients who receive glucocorticoid treatment as a preventative measure in order to avoid the development of osteoporosis. So regarding the bone mineral density, there is a close correlation between the low bone mineral density and increased fracture risk. and a close correlation as well between the increased bone turnover and increased fracture risk. So all of these can increase the bone fracture and risk due to the bone loss. So the first standard deviation will drop about 10% in the BMD, which is associated with doubling the fracture risk. And in type 1, their pathophysiology is most commonly in postmenopausal women or in cases of enhanced osteoclastic resorption or due to high turnover, as well as C and N-terminal collagen crosslink that will degrade the product. Also, treatment with anti-retrospective agents such as estrogen, rolaflexins, or calcitonin, all of which can increase the risk of bone fracture or osteoporosis. So in type 2, the pathophysiology is that it is more common in those aged more than 70. It will have a low turnover, it will have osteoblastic deficiency, it will decrease the alkaline phosphatase and will have low collagen crosslink products, as well as the TX with the parathyroid hormones analogs, including calcium and vitamin D. In addition to this, ethnicity can play a role in the development of osteoporosis, as it has been found that Hispanic women will be at a higher risk of developing osteoporosis. Also, about over the age of 50 in specific, 10% of them will have osteoporosis, and about 50% are estimated to have low bone mass, therefore putting them at a risk for the disease. So Hispanic women get less calcium than the recommended dietary allowance, which could be a factor that increases their risk of osteoporosis. Also, they are twice as likely to develop diabetes, and their rate of hip fracture is rising more than before. In addition to this, African American women get about 50% of their recommended dietary allowance of calcium. Therefore, it also increases their risk of osteoporosis. And certain diseases such as lupus and sickle cell anemia can as well rise the osteoporosis risk in these women. Also, studies have found that osteoporosis is undertreated in African American women, and its risk doubles about every 7 years. Also, they are more likely to die even from hip fracture due to lack of treatment availability or appropriate interventional measures. In addition to this, men are considered to be underdiagnosed with osteoporosis and underrecognized, underreported, as well as in addition to inadequately researched in men in general. Therefore, most studies focus on osteoporosis in women rather than studying its impact on men as well. So about 2 million American men suffer from osteoporosis and million more are at risk. And about 80,000 hip fracture each year are due to osteoporosis in men, and 1/3 will die each year after a fracture. So this will also increases their risk of developing complications after fracture. So the WHO definition of DXA is that about 1 up to 2.5 SD is below the mean, which is considered to be osteopenia. And if it was more than 2.5 below the mean, then this will indicate the presence of osteoporosis. This is a reading of the measurement of osteoporosis. Also, about 75% of all Caucasian women over the age of 75 years will have a higher risk of fracture that is due to osteoporosis. And once OCF is found, about five-fold risk for another of developing another risk or developing another fracture risk. Also, having low body weight and recent weight loss or family history of fracture, in addition to smoking and ages more than 50, all of which increases the risk of developing osteoporosis. So osteoporosis comparison fractures with the risk stratification is if there are two or more osteoporotic compression fracture, then this will increase the risk of developing another one of about 12-fold. Also, BMD, that is at 2SD below the normal, will increase the risk about 6-fold, as well as having family history of vertebral fracture or premature menopause, and even smoking history, all of which increases the risk of developing fractures and osteoporosis. So why do we bother treating this morbidity? It is considered to be acute and chronic debilitating pain, and any altered spinal configuration will lead to reduction of motion and even of strength in these individuals. So significant performance impairment in the physical, functional, and psychosocial domains in older women will be present in most of these cases and will increase their risk of developing more complications later on in life. So having decreased pulmonary function and increased lung disorders has been found with osteoporosis, and increased incidence of sleep disorders has as well been present, and decreased appetite and potentials for malnutrition due to stomach compression in most cases. Also, other factors that have been associated with osteoporosis are clinical anxiety or depression due to its impact on all of these health implications and on their social factors as well. Also, loss of self-esteem and compromised social roles and increased dependency on family and friends, all of which are considered to be associated risk factor or implications in older patients. So about 23% increased mortality rates are compared to women without any spinal fractures. So 2 to 3 times they will be more likely to die from pulmonary causes than those without fracture. So fracture in itself can be a disposing factors for many other health problems, including pulmonary diseases, diabetes, as we have mentioned, and many other associated conditions. So this can be even worse than hip fracture, as 9-fold will increase the relative risk of dying following a spinal fracture alone, and about 7-fold will increase following a hip fracture. This is compared to women without any previous history of fracture as well. So mortality after vertebral compression fracture in the Medicare population has been found to be greatly increased, as about 50% will have a survival rate up to 7 years of max, and more than this, they will be associated with severe complications. So they will significantly and consistently lower than controls in terms of age, gender, and race match. Therefore, this increases their mortality risk in all cases. So for the diagnosis, we need to have a detailed medical history in addition to physical exams and x-rays and bone densitometry to assess their bone density in all cases, which is a very important part. This is the bone densitometry that we can use to assess their bone density. So who should we do this test to? This is with anyone who have fragility fracture, as well as to all women ages 65 and older, in addition to postmenopausal women who are younger than 65 with risk of fracture, as well as men who are over 50 with risk of fracture as well. So for medication, we can give the patient biphosphonate in addition to estrogen replacement therapy and medications that are made from natural hormones and selective estrogen receptor modulator as a preventative measure. So some medication under investigation include vitamin D metabolite, parathyroid hormones, and new biphosphonates to assess for impact in general. Also appropriate treatment of fragility fracture, and if needed, we can conduct surgery to ensure that the patient has the best outcome. And for prevention, we should give the patient vitamin D and calcium. For adults, they should take calcium in about 1,000 to 1,200 units per day. And for vitamin D, we should give them about 200 up to 600 international units of vitamin D per day as a preventative measure. Also, we should ensure that they consume enough calcium in their diet and should avoid any calcium inhibitors in their diet as well. In addition, exercise can be a great method to increase the bone density and improve or prevent fracture risk. So for the medications as well, we can give them biphosphonate in a weekly doses or monthly doses, depending upon the treatment that we choose in general. And this is the basic structure with the clinical tested factors that we can use with the biphosphonate. So this is regarded as the most effective inhibitors of bone resorption. Also, the most dramatic effect is the reduction of the risk of multiple spinal fracture, and its effects may be estimated by measuring the C-terminal and the N-terminal collagen degradation products as well. So these are bound to the minerals who are exposed by the osteoclast, and the osteoclast will resorb the bonds and associated biphosphonates, with the remaining biphosphonates will subsequently be covered until future bond resorption is developing or is in process in order to ensure the best bone mineral factors. So the morphologic response to the osteoclast to the nitrogen-containing biphosphonate is disappearance of the ruffled border, therefore can be assessed by assessing for this method as well. And for the N-containing biphosphonate, the aldehyde and the rhizobinate, these are directly inhibiting the carcinyl diphosphonate synthesis by disrupting the generalization diphosphate production. Other medications include calcitonin in either injection doses or nasal spray, depending upon the patient condition and their appropriate administration route. Also, acute fracture pain treatment will have efficacy that diminishes after 12 to 18 months after its administration. Therefore, this should be taken into consideration when this medication is administered. Another treatment is with parathyroid hormones, the tripratide, with a daily injection for up to 24 months as a treatment or preventative method. Also, there is the anabolic effects that initially with the subsequent with the osteoclastic recruitment, and its effects may be improved even with intermittent dosing with biphosphonate. So in combination with other medications, this can give a better impact or better results. So selective estrogen receptor modulators can as well be used as a treatment in these conditions and is considered to be a successful one. So how do these older populations develop or get fracture that is due to osteoporosis? These some of the minor or low energy cases included picking up grocery bag, even sneezing or a minor fall will lead to fracture, and this is due to the fact that they have a very low bone density, and any trigger, no matter how small it is, will lead to the risk of developing fracture. So the clinical presentation will include back pain, focal kyphosis, loss of height, localized tenderness, fingertips to lower thighs or knees that suggest OSF. These are how the bone or the spinal cord will look like as the patient gets older and as their risk of osteoporosis and lower bone density develop. And for radiography, we can conduct X-rays, bone scans, and MRA to detect their bone mass or assess for the presence of any fracture in these cases. So a plain radiograph can be a marker at a max pain site or can be used for fracture pattern, but will have some limitations, including poor judge of faculties or locations of the fracture as well. Where for the bone scans, these are considered to be excellent predictive value for response to vertebral augmentation, but also have some drawbacks, including poor details and the depth of the level of the details that is to be obtained. So it is best conduct in conjunction with CT scans in patients with MRI, where MRI is not visible, therefore can be very successful in combination with other factors. So this is an example of MRI that is the preferred assessment method in these patients. So when we conduct imaging in these patients, the malignant characteristic will be having convex posterior vertebral wall, destruction of the end plate, as well as posterior elements involvement and soft tissue mass that is present as well. So in the acute status, we will find edema, sclerosis, and intervertebral clefts, which are with the dynamic fracture mobility in most cases that is present. And in the non-operative clinical management steps, these are relatively benign courses of treatment and can be predictive of pain improvement over about 6 to 8 weeks. We can, in these cases, give the patient calcium and vitamin C supplementation, starting with 1500 milligram of calcium and 400 international units of vitamin D in these patients. Also, serum testosterone for men should be assessed, and having elevated alkaline phosphate will suspect the osteomalacia in these cases and therefore should be assessed or tested. So in the non-operative as well, bracing poorly to the tolerated and its efficacy has not been established, but about 30% don't respond to the non-operative therapy and therefore will require some sort of interventional therapy treatment. And in the vertebral body augmentation, such as kypholoplasty and vertebroplasty or spinal restoration or restructions, can be conducted in the patient who are not responding to non-operative treatment and will require interventional operative treatment. So in the vertebroplasty, the postural reduction in the prone positioning with augmentation of the vertebral body with BBMA through the cannula, as well as kyphoplasty that adds balloon tamp to the reduction of the steps as an operative intervention. So some of the contraindications include infections, coagulopathy, unstable fractures or retroblutions of the fragments into the canals, and about increasing the risk in 3 folds in the collapse that may be technically impossible. So this is relative to the contraindication after the intervention. Therefore, this can be indication of why it is to be contraindicated. So the mechanism of the vertebral augmentation is that in the biomechanisms, including the amount of the BMMA weekly that correlates with the strength and the stiffness, as well as the location of the cements that doesn't affect the loading of the behavior of the bones as well, and the stiffness that is equal to the administered dose in these patients as well. So the outcomes will include in the vertebral augmentation versus the non-operative care is a significant pain level and functional improvement as the most common positive impact of these interventions. Also, deformities with height loss, having low pressure injections, and less cement extractions, as well as equivalent pain relief, can as well be detected. So the biomechanical and clinical studies can be a great indicators with equal restoration of height, strength, stiffness in the stapler model between the kypholoplasty and the vertebroplasty, and the cavity creation system with the osteoblasty, as well as a positive impact of these factors. So it will have as well immediate pain relief that is equal, with slightly higher risk of extrusion with vertebroplasty due to a lower viscosity of the vertebral blast. It will also have a slight advantage with improving the height in the kypholoplasty and insignificant clinical differences in most of the outcomes that are to be accounted for. So the fracture age and ability to reduce the fracture can be or has been looked at in different studies, with the reduction ability of fractures in the acute cases and subacute cases that can range between 1 up to 6 months. So the time since the initial fracture alone doesn't predict the ability of the balloon to reduce the risk, but MRI will reveal local edema and acute component of the fracture as well. So about 75% of chronic fracture can be expanded, and about 50% will have more than 8 weeks expandable, but earlier would be better to assess for its impact or appropriate interventional methods to be implicated. So in cancer and spinal fracture, there are insufficiency of the fracture, but there are bone metastases and multiple myelomas that are detectable. And in the multiple myelomas, about 15 to 30% of patients with multiple myeloma will sustain new spinal fracture annually. And approximately 75% of patients with multiple myeloma have bone pain at the time of diagnosis. Also, 50% of myeloma patients with bone pain in the back have vertebral fracture. Therefore, this should be assessed when they are first diagnosed. So the outcome augmentation with the vertebral tumors include complication profiles that are similar to the non-tumor patients in all cases. So open surgery can be an intervention that is to be applied with patients that don't have neurological defects. It is also considered to be risky, difficult, and complicated by comorbidities with fixation issues that are associated as well. So indication for reconstruction in osteoporosis, including in the case of neurological defects, which are to be very rare conditions. Also, painful fracture that are not amenable to kypho or vertebroplasty, in addition to progressive deformity with intractable pain in these cases. So the osteoporotic fixation is a pedicle screws that most sound with wires and hooks that can be used in conjunction with screws. So insection of the torque directly correlates with the pull-out strength and will have minimal bone mineral density that is unknown in these cases as well. And even though that insertional torque is important, oversizing the screws too much will places the pedicle at risk for future fracture. So 40% of fracture rate when screw diameter greater than 70% of the outer pedicle diameter is predicted in these cases. Also, osteoporosis will often coincide with spondylosis in combination with stiffness, weakness, spine that can be disastrous. Also, odontoid fracture that are very difficult to manage, in addition to HALO fixation challenging and anterior cervical fixation challenging as well. So in conclusion, we should avoid the development of osteoporosis and fractures. Also, having low threshold to investigate the bone density, as well as treatment as needed. And we should anticipate the fixation of the problem in itself rather than treating the fracture after it has developed. So another very common bone disorders that is related to calcium and vitamin D is rickets. So it is a disease of growing bone that is due to unmineralized matrix as the growth plate. So it occurs in children only before fusion of the epiphysis in the development period. So the normal bone process includes calcium and phosphate, which constitute the crystalline component of the bones, and its deficiency will lead to diseases including rickets or osteomalacia. And in rickets, it is a deficiency in the mineralization at the growth plates. Also for osteomalacia, this is impaired mineralization of the bone matrix in these patients. So the open plates occur in osteomalacia and in rickets, where the closed plates happens in osteomalacia only. So this can be the differentiating factor in these conditions. So rickets is a disease of the growing children. It will impair the mineralization of the growth plate and the osteoid. It will also have low serum phosphate that is fundamental to the pathogenesis of the rickets. So the normal growth plate will have apoptosis of the hypertrophic chronolithias caused by phosphate ion, where in the ratchet growth plates, this will have hypophosphatemia and no apoptosis of the hypertrophic chondriocytes in these cases. So for the etiology, it can be due to vitamin D disorders, that is the most common case. Also, it can be due to calcium deficiency and due to phosphorus deficiency as well. Also, it can be due to renal losses in some patients. In addition, it can be due to nutritional deficiency, secondary malabsorption, vitamin D dependent rickets type 1 or type 2, also due to chronic renal failure, and due to low intake of diet, as we mentioned, premature infant with rickets of prematurity, and due to malabsorption, such as due to primary disease or dietary inhibitors of calcium absorption. So these can be due to either vitamin disorders, vitamin D disorder, or due to calcium disorder. Also, It can be due to phosphorus deficiency, in which inadequate intake can be present with premature infants and aluminum-containing antacids in these cases. In addition, it can be due to renal losses due to X-linked dome of the hypophosphatemic, as well as due to autosomal dominant hypophosphatemic factors and hereditary phosphatemic rickets with hypercalciuria and overproduction of phosphatemine due to Fanconi syndrome, dental disease, and distal renal tubular acidosis as well. So the clinical features of rickets include failure to thrive, listlessness, protruding abdomen, muscle weakness, especially the proximal ones, and fractures as well. So in the head, it can be prominent by carnitop or frontal bossing, delayed frontal closure, delayed dentition as well, or caries, and craniosynostosis. Where in the chest, it can be detected by ratchet rosary, Harrison groove, and respiratory infections, as well as atelectasis. So the hypocalcemic symptoms include tetany, seizures, stridor due to laryngeal spasm as well can be present. So this is an example of rickets development in children as well. So for the radiology, we can conduct the frying, cupping, widening of the distal end of the metafaces, ratchet rosary, courses of the trabeculation of the diaphases, and generalized rarefaction as well. This is an example of how we can detect rickets in the presence of imaging as well. So for vitamin D deficiency, it is the most common cause of rickets, and people at risk include children aged between 6 and 24 months of age, also dark-skinned people and premature babies, as well as those who are exclusively breastfed. This is a diagram of the development of rickets in these cases. So some sources of vitamin D include fish, liver, and oil in the human milk, for example, as well as exposure to sunlight. So vitamin D requirement under the age of 1 is about 400 international units per day, and over 1 year it should be 600 international units per day. So the pathogenesis include parathyroid hormone having high secretion. It will be decalcification of the old bond, will lead to calcium present in the blood that is in normal or low amount. Also, phosphate in the urine and in the blood will decrease with increasing decreasing the calcium and phosphorus product, therefore will lead eventually to rickets. So for the laboratory finding, we can find hypocalcemia or normal calcium levels. This can be hypophosphatemia of vitamin D that is low, and there are variation in its level. It can be low, normal, or even high. And it will be low when there is a severe vitamin D deficiency, but the metabolic acidosis that is secondary to parathyroid hormone-induced renal bicarbonate wasting. It can also be found a generalized aminoaciduria as well. So for diagnosis, we should take history of any poor vitamin D intake, as well as risk factors for decreased cutaneous synthesis, and having radiographic changes that is consistent with rickets, and having typical laboratory findings and a normal parathyroid hormone levels that is almost never present. So it occurs with vitamin D deficiency and suggests a primary phosphate disorders as well. So for treatment, there are two strategies: the SOS therapy, with high doses of vitamin D that are administered orally or intramuscularly in about 2 to 4 doses over 1 day. Also, there is the daily therapy over 4 to 6 weeks, and either of which of these two strategies should be followed by daily vitamin D intake of about 400 international units if the patient is less than 1, and 600 units if the patient is over the age of 1. So we should also ensure that children receive adequate dietary calcium and phosphate as well in these cases. There is also a congenital vitamin D deficiency type of disorder that is rare and occurs in severe maternal vitamin D deficiency only during pregnancy. And risk factors include poor dietary intake of vitamin D, lack of adequate sun exposure, and having closely spaced pregnancy. Therefore, the mother will have low stores of vitamin D as well. There is also the clinical features, which include symptomatic hypocalcemia and tetany, as well as intrauterine growth retardation, decreased bone ossification, and classic ratchet changes. And for treatment, vitamin D supplementation with adequate intake of calcium and phosphorus is recommended. As well as for the prevention, we should use prenatal vitamins that contain vitamin D in order to prevent its development during infancy. So the secondary vitamin D deficiency, its etiology is due mostly to inadequate absorption, decreased hydroxylation in the liver, or increased degradation of the vitamin D as well. So it occurs secondary to the liver and GI disease, such as cholestatic liver disease, defects in bile acid metabolism, as well as cystic fibrosis, pancreatic dysfunction, celiac disease, or even Crohn's disease, and any intestinal lymphogenetic and after intestinal restrictions as well can be detected. So the degradation of vitamin D is due to phenylprotein and phenothiene cytochromes of B45 indicators. And for its treatment, we should use high doses of vitamin D in daily doses, and alternatively, it can be treated with vitamin D supplementation. So for the vitamin D dependent rickets, which is known as type 1 rickets, this is considered to be an autosomal recessive disorder. in which it's due to mutation of the gene in the endocoding renal 1-alpha hydroxylase, and it can prevent the conversion of vitamin D into its active form. So it will present during the first or second year of life with classic features of rickets, and symptomatic hypocalcemia signs will develop as well. So for the lab finding, we can find either normal level of vitamin D or low levels of its active form and high level of parathyroid hormone. Also, we can find low serum phosphorus level. And for treatment, we should have long treatment with 0.25 up to 2 grams per day of active vitamin D to ensure adequate intake of calcium as well. In addition, we should monitor for periodic urinary calcium excretion, and having excessive dosing can cause hypercalciuria and nephrocalcitonin. Therefore, it should be avoided. So we shouldn't overtreat them, but we should give them their required or appropriate dose in all cases. So in the type 2, which is the vitamin D dependent rickets, this is as well autosomal recessive disorder that is due to mutation in the gene encoding vitamin D receptors. It can prevent a normal physiological response to the active form of vitamin D, and in most cases, it will present during infancy. So about 50 to 70% of children will have alopecia, and it is less commonly epidermal cyst that is seen in these cases. Therefore, should be investigated under these conditions. So for the lab finding, we can find extremely elevated levels of the active form of vitamin D. And for treatment, we should give them high doses of vitamin D2 or the active form of vitamin D, as well as calcium in about 1,000 up to 3,000 milligram per day, as well as about 3 to 6 month trial of high doses of vitamin D in addition to oral calcium supplementation. Also, giving them intravenous calcium who don't respond to the oral treatment is recommended as well. And in cases of chronic renal failure, there is decreased activity of the 1-alpha hydroxylase that is found in the kidneys. Also, it can lead to diminished production of the active form of vitamin D, and patients can have hyperphosphatemia that is due to decreased renal excretion. So for treatment, we should give the patient therapy with calcitriol, as well as it can lead to adequate absorption of calcium, and it can directly suppress the parathyroid gland's activity as well. we'll be taking a 15-minute break for Salat al-Isha. Causes of rickets are the chronic renal failure, in which there is a decreased activity of the 1-alpha hydroxylase in the kidneys. So this will lead to diminished production of vitamin D, the active form of vitamin D. Also, the patient will have hyperphosphatemia due to decreased renal excretion. So for therapy with calcitriol, we should start it, and it will lead to adequate absorption of calcium, and it can directly suppress the parathyroid gland from overproducing its associated hormones. So the etiology of calcium deficiency is that, first of all, rickets occur secondary to inadequate dietary calcium intake that is less than 200 milligrams per day. And in children who receive parenteral nutrition without adequate calcium, it can be an etiological factor as well. Also, early weaning from milk and milk products can all be disposing factor for the development of rickets and calcium deficiency. In addition to malabsorption of calcium that can occur in celiac disease or in intestinal abetoloproteinemia and small bowel resection in certain conditions. So for the diagnosis, lab finding can include increased level of alkaline phosphatase, parathyroid hormone, as well as the active form of vitamin D. And calcium levels may be normal or even low in these cases, as well as decreased urinary excretion of calcium and having low phosphorus level that is due to renal wasting of phosphate, as well as in coexisting nutritional vitamin D deficiency that have low active vitamin D level. So in these cases, we should provide adequate calcium and dietary supplements in a dose of about 700 milli per kg per day, as well as vitamin D supplementation with discouraging early cessation of breastfeeding, as well as increasing the dietary sources of calcium in these cases. There is also another type, which is rickets of prematurity. This is rickets in very low birth weight infants, and its pathogenesis is due to 80% transfer of calcium and phosphorus that occurs during the third trimester, as well as premature birth that is interrupting the process of transferring these levels from the mother to the fetus, as well as in most cases of rickets, it occurs in infant with a birth weight that is less than 1,000 grams in general. Also, risk factors include having low birth weight and younger gestational age, in addition to unsupplemented breast milk and standard infant formula that doesn't contain enough calcium and phosphorus. Also, cholestatic jaundice in the preterm infant, and prolonged use of parenteral nutrition and medications such as diuretic and corticosteroids to prevent the absorption of calcium and vitamin D, in addition to lowering the density of the bones. So the clinical manifestations include or occurs in about 1 to 4 months after birth. Also, infants can have non-traumatic fractures of the legs, arms, and ribs as well. And Ratchet's respiratory distress usually develop in more than 5 weeks after birth, as well as having frontal posing, ratchet rosary, craniotomy, and widening of the wrist and the ankles, and having long-term effects in the animal hypoplegia. So laboratory findings include having serum phosphorus level that is low, also normal level of vitamin D, as well as high level of the active form of vitamin D, in addition to hypercalciuria, which indicates that phosphorus is the limiting nutrient for the bone mineralization, and alkaline phosphatase levels that are often elevated as well can be detected. So for screening tests, there is weekly measurement of calcium, phosphorus, and alkaline phosphatase, and X-rays for rickets at about 6 to 8 weeks of age can be conducted. And for prevention, we should have adequate amount of calcium, phosphorus, and vitamin D in all cases, as well as having early transition to enteral feeding and having human milk fortified with calcium, as well as phosphorus or preterm infant formula with high concentrations of these as well. So the etiology of the phosphorus deficiency include inadequate intake, mostly in premature infant and in aluminum-containing antacids, where in the renal losses, the etiology is mostly due to an X-linked DOM hypophosphatemic or due to autosomal dominant hypophosphatemic disorder. So the autosomal recessive hypophosphatemic can be also an etiological factor, and having hereditary hypophosphatemic rickets with hypercalciuria, in addition to overproduction of phosphotyramine and Fanconi syndrome with Dent disease or distal renal tubular acidosis as well. So for the phosphotinine, this is a humoral mediator that decreases the renal tubular reabsorption of the phosphate, as well as decreasing the activity of the renal 1-alpha hydroxylase. So there are increased level of the phosphotinine that causes many of the phosphate wasting disorders in these conditions as well. So this is the process of the development of these conditions when there is a deficiency. Also, this is an illustration of the X-linked dominant hypophosphatemic rickets and the autosomal rickets with the autorecessive phosphatemic rickets and the hereditary forms, with conversion or summarization of these factors in these conditions. So for the overproduction of the phosphotinine, this is mostly tumor-induced osteomalacia, as well as McCune-Albright syndrome that can be disposing factor, and having epidermal nevus syndrome, as well as neofibromatosis. So all of these produces phosphate deficiency that can lead to ricket, but it is more common to be the leading cause in adults rather than in children. So in Fanconi syndrome, this is secondary to the generalized dysfunction of the proximal renal tubules. Also, there is a loss of the phosphate, amino acid, bicarbonate, glucose, and urates as well. And there is hypophosphatemia that is due to phosphate losses that will lead in most cases to rickets. So the proximal renal tubular acidosis that is due to bicarbonate losses lead to bone dissolution, and failure to thrive is a consequence of both rickets and RTA as well. So in the distal renal tubular acidosis, this is usually manifesting with failure to thrive, as well as metabolic acidosis with an inability to acidify the urine. Also, the hypercalciuria and nephroclosis are typically present, with rickets that is variable, and it responds to alkali therapy in most cases. So these are the laboratory findings of disorders that causes lipid, for example, in vitamin D deficiency or in type 1 or 2, or those due to chronic renal failure or dietary deficiency. So depending on the cause, then the laboratory finding will be varied. Therefore, these should be assessed carefully and monitored for their levels as well. So the approaches to ricket, including having diet history and assessing for any associated vitamin D deficiency, also having cutaneous sun exposure such as culture and clothing that need to be assessed, in addition to maternal risk factors for vitamin D deficiency and malabsorption such as GI syndromes or symptoms and liver disease as well. So all of these should be carefully assessed. Also, child on anticonvulsant medication or antacid should be assessed for the development of rickets, and renal diseases such as chronic renal failure, polyuria, or Fanconi syndrome. So all of these should be assessed carefully when we are assessing for rickets risk. In addition to taking detailed family history of short status, bone disease, unexplained death of sibling that is due mostly to cystinosis or Fanconi syndrome, as well as alopecia and vitamin D dependent rickets that is type 2 or known to be as type 2. So assessing for these factors is very important in order to ensure that we understand the cause of rickets and we can prevent its progression as well as its development in other family members as well. So this is a diagram of rickets and its contributing factors that can help us in determining the treatment or choosing the appropriate approach to the treatment as well. So in summary, many cases of rickets are nutritional and respond to vitamin D therapy. Also, a single dose of 6-alkaline phosphate in intramuscular doses is the most practical way to treat the nutritional rickets along with calcium. Also, in cases of non-response, then the renal causes should be considered and assessed for their presence, in addition to having a normal serum creatinine that will exclude osteodystrophy and any presence of acidosis that points toward RTA. In addition to hypercalciuria that occurs due to bone resorption as a result of chronic acidosis and decreased renal tubular resorption of calcium, and further differentiation between type 1 and 2 is by the urine pH level. So the absence of acidosis will indicate either hypophosphatemic rickets or vitamin D deficiency rickets. And the hypophosphatemic rickets will show renal phosphate wasting, and vitamin D deficiency rickets can be identified by measuring the serum vitamin D levels to assess for any associated conditions. So in these cases, the treatment will focus on initiating vitamin D supplementation and calcium supplementation as the most commonly used approach of treatment. So vitamin D is a fat-soluble vitamin that is present in animals, plants, and yeast, and also has several important functions in the body. So technically, it should be considered as a hormone, such as testosterone, because it is synthesized by the body, by which we mean the skin, from the sunlight. This is by ultraviolet B-ray and wave bands. So it is transported by the blood and activated and then acts on specific receptors in the targeted tissues. So feedback regulations of vitamin D activation occurs by the plasma calcium level and by the active form of vitamin D once it is transferred to its active form. So the historical background is that in 1919, it was established that rickets was due to deficiency of dietary factors and lack of sunlight exposure. And the American researchers Elmer McConnell and Margaret Davis in 1922 discovered a substance in the cod liver oil and its structure as determined in the 1935. So they called it vitamin D because it was the fourth vitamin to be named after vitamin A, B, C, D. Therefore, it was named as D. So in chemistry, there are two chemical forms of vitamin D2, which is the ergocalciferol, and vitamin D3, which is the cholecalciferol. So the natural forms of vitamin D is for animals and man, that is D3. This can be produced in their bodies from cholesterol and 7-dehydroxycholesterol. So both of which are inactive forms that need to be formulated and activated in the body to the active form of vitamin D. So an alternative to vitamin D2 is commercially prepared from ergosterol that is present in yeast and can be taken as supplements. So the molecular structure of vitamin D is closely allied to that of the classical steroid hormone in many cases. And this is the chemical structure of vitamin D, as you can see, in the active and in the inactive forms that need to be activated. So there are two main sources of vitamin D. About 90% are synthesized in the skin via the ultraviolet rays due to light exposure, in which it can give us the cholecalciferol. So, and 10% from food, which is the ergocalciferol, which is vitamin D, the inactive form, all of which are converted into the active form once ingested in the body. And some dietary sources of vitamin D include fatty fish like tuna, mackerel, and salmon, as well as cod liver, oil, and foods that are fortified with vitamin D, like some dietary products, orange juice, soya milk, and cereals as well. Also, we can find vitamin D in beef liver, in cheese, and egg yolk, as well as we mentioned milk and orange juice. But the richest source is fish liver oil, and the cheapest source is sunlight exposure. So any person can have an active source of vitamin D regardless of their social factors. And for the daily requirement, children and adults require about 400 international units of vitamin D on a daily basis, where in pregnancy and lactation, they also require the same amount, 400 international units, but people over the age of 70 would require 800 international units per a day. So 1 microgram of vitamin D will be equivalent to 40 international units of vitamin D. So the synthesis of vitamin D, as we mentioned, in human is through the skin, where in plants it is through yeast production. And for metabolism, the sources are the skin and the diet. It will be stored in the form of 25-OH vitamin D3, which is known as calcidiol, where the active form is the 125-OH vitamin D, the calcitriol. So in the MOA, the steroid hormones will bind to the VDR in the nucleus to upregulate the gene expression in the targeted cells for the conversion of vitamin D into its active form. So the absorption will be converted from vitamin D3 and D2 into the endocytes, which is the upper small intestine, and the mechanism behind which is along with lipids, and it requires bile salts to be present for the conversion to happen or to be activated. So it is a fat-soluble vitamin as the rest of the associated group. After that, it will be transported via binding to vitamin D binding globulin to be transferred into the cells and be stored in the body. So synthesis of the active form of vitamin D will have the active form, which is the 1,25-dihydroxycalciferol, or more commonly known as calcitriol. So this is the active form of the vitamin. This is the process in which the metabolism and the function of vitamin D develop in the body in different organs and different systems throughout the body. So calcitriol is the biologically active form of vitamin D, and it is responsible for the regulation of the plasma calcium and phosphorus as well. So the action of the calcitriol is that it increases the intestinal absorption of calcium and the phosphate as well by increasing the synthesis of calcium binding protein, the cal binding B28K. Also in the bones, it will help in mineralization of the bones at low doses, and it can help in mobilization of calcium from the bones at high doses level. Also, it can have increased reabsorption of calcium and phosphorus, and it will decrease the excretion of calcium and phosphorus depending upon its level in the blood and in stores of the body. So the PTH effects, which is the parathyroid hormone, it will increase the tubular reabsorption of calcium and will stimulate the kidneys to produce the active form of vitamin D or D3. Also, it will stimulate the activation of the osteoclast, which dissolve the mineralized collagen matrix in the bones, therefore causing osteopenia and osteoporosis with increasing the risk of fracture. So this will cause phosphaturia, and a low calcium to phosphorus products will lead to decreased mineralization of the collagen matrix, which can increase the rickets in the kids and also osteomalacia in adults. This is the endocrine, paracrine, and the intracrine function of vitamin D, in which it can help in calcium homeostasis as well as muscle health and bone health, with regulation of blood pressure and cardiovascular function, and the neurodevelopment with immunomodulation. Also, it can be helpful in immune modulations by preventing autoimmune disorders and controlling invading pathogen activations as well. Also, it can be helpful in regulation of the cell growth and differentiation in most cases. So, vitamin D status of levels in the normal level should be more than 30. The insufficiency is between 21 to 29 milligram per milliliter. And if it was less than 20, it will be regarded as deficient. And if it was less than 10, then this will be regarded as a severe deficiency. So the exact cutoff value for deficiency or insufficiency remains controversial and can be different between different organizations. But researchers concluded that having low level of vitamin D that is less than 18 was independently associated with increase in all causes mortality in the general population. So even if it was a minor decreased level of vitamin D, then this can be associated with a negative impact over health. So risk factors of vitamin D deficiency include elderly individuals who are older than 65, also people with darker skin color, people who have no sun exposure, and those following a strict vegan diet, and obese individual or nursing home resident, as well as patient on medication that induce the B450 enzyme activity, as well as individuals with kidney disease and those with low bone mass or osteoporosis, and individuals with non-vertebral or hip fracture, as well as those with history of falls, therefore will be at increased risk of fracture due to deficiency. So the main reason for low level of vitamin D are lack of vitamin D in the diet, that is often in conjunction with inadequate sun exposure. Also, the other reason is inability to absorb vitamin D from the intestine and inability to process vitamin D due to kidney or liver disease. Also, in the case of inadequate sun exposure, the sunscreen with SPF more than 50 will block about 99% of vitamin D synthesis and will have pigmented skins and aging older than 65, or in the winter season, as well as physical agents that block the ultraviolet rays exposure, or clothing and season air pollution, or cloud cover and latitude and altitude as well. So in the case of decreased absorption as a cause of vitamin D deficiency, this can be present in bowel bypass surgery, or in Crohn's disease or celiac disease, as well as in fat and cholesterol absorption inhibitors. Where in the case of inability to process vitamin D, these are most often due to impaired production of the active form of vitamin D due to liver disease. Also, impaired production of the active form due to kidney disease, such as hypoparathyroidism, oncogenic osteomalacia, and having an X-linked hypophosphatemic rickets as well. Some other causes of vitamin D deficiency include breastfeeding or medications such as steroid that decreases the half-life of vitamin D, also barbiturate, phytonine, and rapamycin that can induce the hepatic B45 enzyme to accelerate the catabolism of vitamin D as well. Also, ketolinizate that impaired the hydroxylation of vitamin D to the active form, as well as increasing the degradation of the active form of vitamin D with medications such as isoniazid and phytonine. There is also some cases of target organs resistance that is due to vitamin D receptor mutation and therefore inability to bind to the receptor or be transported into the cell. So, in specific, in India, which is a country with abundant sunshine but still a high prevalence of vitamin D deficiency that has been documented, it is present in more than 70% of the population. Having a subclinical vitamin D deficiency is very common in India in all the age groups and both genders across the country. So, skin complexion, poor sunlight exposure, vegetarian food habits, and low intake of vitamin D fortified food could be attributed factors to the high prevalence of vitamin D deficiency in India. So, malabsorption is the commonest cause of vitamin D deficiency in India, with its deficiency that is likely to play an important role in the very high prevalence of rickets, osteoporosis, cardiovascular disease, diabetes, cancer, and even infections such as tuberculosis. So it can be a greatly disposing factor due to its high presence and the associated conditions that are also detectable in these population. So the vitamin D defects are related to systematic disorders, including autoimmune disorders such as rheumatoid arthritis, inflammatory bowel disorders, type 1 diabetes, and SLE or psoriasis. So in the cardiovascular disorders as well, this can be due to hypertension, CAD, cardiomyopathy, CHF, or coronary calcification, and peripheral vascular disorder. All of these can be associated factors with the development of vitamin D deficiency. Also, due to the endocrine and metabolism factors, a primary hyperparathyroidism, type 1 and 2 diabetes, as well as metabolic syndromes can all be associated with vitamin D deficiency as well. And the hemopatotic system, including anemia, leukemia, or infections with childhood asthma, recurrent UTI, and tuberculosis, are all of which can be disposing factors for the development of vitamin D deficiency or associated with it. Also, in the musculoskeletal system, having rickets and osteomalacia, osteoporosis and fracture, myopathy, and fibromyalgia are always associated with vitamin D deficiency. In addition, malignancies with breast cancer, colon cancer, pancreatic, ovarian, and prostate cancer are all associated with vitamin D deficiency as well. And for the nervous system, having multiple sclerosis, stroke, and headache as well are associated with vitamin D deficiency. And some psychiatric disorders such as depression, mood swings, and the reproductive systems such as dysmenorrhea, COPD, gestational diabetes, and preeclampsia are as well associated with vitamin D deficiency. So vitamin D and related disease include rickets in children and osteomalacia in adults, and it can increase the risk of osteoporosis in all of these conditions. So rickets and osteomalacia are disorders of the mineralization of the newly synthesized bone matrix, the osteoid, and in children, a defect that can occur in the growth plate and in the mineralization of the cartilage, leading to characteristic deformities, which are known as rickets. Where in adults, it occurs after epiphyseal closure and involve only the bones, which are the osteomalacia. So for rickets, the age incidence is about 4 months up to 2 years, and the clinical feature or symptoms include irritability and restlessness, rocking of the head in below and sweating of the forehead as well, in addition to delayed dentition and delayed milestones development. And some signs include carinotobos, frontal posing, ricketry rosary, bowed legs or knocked knees, delayed closure of the antifrontilla, and pot belly or Horsen's scoliosis. So the radiological changes include cupping or widening and fraying of the lower end of the radius and ulna, as well as widening of the rest of the soft tissue shadow, where the biochemical changes include increased alkaline phosphatase, hypophosphatemia, and hypocalcemia, with decreased vitamin D level, and treatment of 6-ultraviolet vitamin D3 orally or in the induced rapid healing within 3 to 4 weeks, then giving about 400 international units on a daily basis. These are some features of rickets that are most commonly seen in children who have the condition. So vitamin D resistant rickets type 1 include the autosomal recessive, which is failure of the conversion or the synthesis of the active form of vitamin D that is due to inactivating of the mutation in the renal hydroxylase enzyme, with some clinical features including those similar to the ones that are found in infantile rickets, and their diagnosis is made or is usually first suspected when the patient fails to respond to vitamin D supplementation. So biochemical features of type 1 disease are similar to vitamin D deficiency, except that the level of the 25 vitamin D are normal. So for the treatment, it is treated with the active vitamin D metabolite with or without calcium supplementation, with increasing the doses on a gradual basis in order to ensure the patient has the most appropriate tolerance to the medication administration. So vitamin D resistant rickets type 2 is an autosomal recessive type in which the defect of vitamin D receptors is present and can impair the ability to activate the transcription and even impairs the response to the active form of the vitamin D. So approximately 50 to 70% of children will have alopecia, which tend to be associated with more severe form of the disease if it was in fact present. So it is extremely difficult to treat, but in sometimes it will respond partially to very high doses of the active form of vitamin D or its metabolites and calcium and phosphorus supplementation. So combining these three approaches can be a suitable adjustment factor. So hypophosphatemia rickets is an X-linked dominant disorder that is inherent in an X-linked dominant manner. And this means that the defective gene is located on the X chromosome. So only one copy of the defective gene is sufficient to cause the disorder, and the males are normally homozygous and will have only one copy of these factors. So defects in the phosphate and pyrophosphate metabolism can be detected, and the diagnosis is made on the basis of an early age at the onset and presence of hypophosphatemia with renal phosphate wasting in the absence of vitamin D deficiency. So osteomalacia is the softening of the bones that are caused by defective bone mineralization that are secondary to hypocalcemia, hypophosphatemia, and vitamin D deficiency. So the cause of adult osteomalacia are varied, but ultimately will result in vitamin D deficiency. And its manifestations are with bone pain, severe myalgia, proximal muscle weakness, and waddling of their gait. And the radiological feature include pseudofracture and decalcification along with the course of major arteries. And the treatment is with vitamin D deficiency that is corrected with 60,000 international units given once weekly for about 6 weeks until their level are corrected. So diagnosis of vitamin D deficiency is that the key diagnostic test is the demonstration of the decreased serum vitamin D values. So having low values and normal level of the inactive form will suggest defective absorption or transportation of vitamin D in the body. And the treatment of the deficiency should be directed at the underlying disorder and the severity of the condition as well. So in patients with vitamin D hydroxylation that is impaired, then metabolite that doesn't require this activation should steps with the treatment of the choice. And if the pathway that is required for the activation of vitamin D is intact, then having severe vitamin D deficiency can be treated initially with 50,000 international units per weekly doses. So after treatment, we should monitor with the most effective method to monitor the treatment of the vitamin D deficiency, such as the serum and urinary calcium measurement. And in patients who are vitamin D depleted, then and even taking adequate calcium supplementation, having 24-hour urinary calcium excretion should be in the range of 100 up to 250. Also, there are some toxicity associated with high doses of vitamin D, including multiple products that contain vitamin D intake with the toxic feature such as anorexia, nausea, vomiting, deposition of calcium in the soft tissues like the kidneys, and developing kidney stones at will. So vitamin D preparation are different, including the vitamin D2, 3, and D3, the active form, and choosing the appropriate form will depend upon the patient condition and its associated enzyme. For prevention, we should have a sufficient sunlight exposure, taking adequate dietary sources of vitamin D, and food fortification in children and pregnant women. So we have reached the end of our webinar for today. If you have any questions, please do send them on the chat. And if not, we will see you again tomorrow, inshallah.